proper nutrition and so forth to keep the patients alive. These are some of the foundational trials that have shaped our current standard of care. I think they're important to still include them. They still serve as the backbone with carboplatin paclitaxel. So we first looked at using paclitaxel in substitution for cyclophosphamide, showed an improvement in overall survival as well as progression-free survival. And we then were able to do that with cisplatin, and we were then able to substitute the cisplatin with carboplatin, showing at least as good of overall survival, slightly better, and sustained PFS as well. We're being able to take this cumbersome inpatient regimen to the outpatient regimen that can be done globally, and currently serves as a standard. And tissue diagnosis or cytology diagnosis confirming ovarian primary peritoneal fallopian tube cancer, followed by the interval cytoreductive surgery and then additional chemotherapy. And then we talked about intraperitoneal and HIPEC, the intraperitoneal as well. I'll have a few words on that. And then you can see the other trials associated here. So lots going on in this world. It's led to a number of drug approvals here in the United States. This is the FDA approval mechanism here. And you see those red lines, and those have all been studies that have seen retractions. And I was faulty in not putting the newest retraction, which I'll talk more about here in a little bit, especially when we get into the PARP section. Looking at the wrapper frontline all comers that was retracted in June of 2025. So that has changed as well. Intraperitoneal trials, so these are the trials that have shown anywhere between 25 to 35% improvement in either progression-free and or overall survival. And you can see here the GOG 104 SWOG trial by David Alberts, Ari Markman, GOG 114, Deb Armstrong's GOG 172, and then Jovan Walker's trial, which was the most contemporary, which did not show improvement at all in the hazard ratio. So we saw no improvement there in terms of PFS, which was the primary endpoint. It gets even more interesting when you start looking at HIPEC, and I could spend probably an hour talking about this as well. So lots of trials here, but they've all been heterogeneous in their collection of data. In other words, they included different patients, there have been different genomics, there have been different temperatures used for the HIPEC, and we've seen different outcomes. And so people feel very strongly. Recurrence-free survival in this case is very minimal. So here's the difference in the recurrence-free survival. You can see there's a gain there of 3.5 months. Hazard ratio looks pretty good. Curves are fairly impressive there in terms of what you see, but an even bigger difference in overall survival with a single intervention, which is very interesting. Who are these patients? Why is there a difference from what was seen with other IPEC studies? We are trying to sort that out in the GOG. These are some of the toxicities you see, which were pretty well controlled in the Van Drill study, but have been shown to be higher in other studies. We're trying to figure this out in the GOG with GOG 308 trial. More to come on this. The FDA regulatory has changes. We're in the midst of a major amendment right now, so that these patients are only going to be looked at in homologous recombination deficiency test negative or the homologous recombination coefficient group. And so we'll see with this change how this data is taken into the current regulatory environment and what the impact is around it. Okay, also allowing bevacizumab to be used in this trial as well. Dose dense got its start in Japan in terms of phase 3 data. Dr. Katsumata and colleagues published their data, and there were 2 data sets that came out in terms of follow-up. Progression-free survival improved using paclitaxel on day 1815 instead of the usual, using paclitaxel dose dense over our every 3-week schedule. The problem with this was that when we looked at it, you can see the data here, impressive improvement, and this spurred a number of other trials throughout the world which did not show the same benefit. You can see those curves right on top of each other for GOG 262. Although there's a caveat for those that didn't receive BEV, may have had some advantage to the dose dense regimen. MITO 7 did not show an advantage. Not a significant advantage. So many people wonder if it's the pharmacokinetics of the Eastern Asian population and or what else is going on there. But why do we do maintenance in ovarian cancer? This is an area that has received a tremendous amount of investigation, clinical trials. We think that we're able to perhaps kill some of those stem cells, if you will, or those resistant cells that aren't killed initially with chemo with giving additional treatment. In this case, usually bevacizumab has been looked at. And now we've seen a number of other methods being used, such as PARP inhibitors, as well as you'll see soon antibody drug conjugates in this setting as well. The question is, can we improve cure? And that goes back to the biologics of this, where you can see in the green line there, once you get into over 10 to the 9th cells, so you need billions of cells to see something clinically to your naked eye. But can we change that with giving maintenance therapy to bring these cells down to hopefully 0? And that's where we're going to cure. That's the real question, and that's what's fueled our interest. We've had 2 excellent studies, frontline bevacizumab, both in the New England Journal of Medicine for GOG 218 and ICON 7, showing a consistent advantage of anywhere between 3.5 to 4 months PFS, or if you censor for CA-125, then the advantage for PFS is actually closer to 6 months. So where are we now in terms of frontline ovarian cancer? And again, the approvals we talked about, and the impact. So with the now, this is where the schema as we stand now, and these are the data to support it. In terms of treatment with PARPs and bevacizumab, and we now, with the HRP population, have only surveillance for those that were not on BEV or not on BEV. If you look at the outcomes, like the canceled sign here as of June 2025 in the United States, love to hear what, that's the problem with not being there. Is usually, I spend the day before talking to all of you, see what are the current standards in the kingdom to find out how the regulatory activities in Europe and in the United States influence selection therapy in Saudi Arabia and throughout the rest of that region. This is looking at, sort of where we've been, if we shift now to looking at PARPs and incorporating Bev plus PARP on the far right. Understand soon that we'll have the ADCs coming into vogue, and so I think there's a number of things that we can look at that we've learned with an examination of frontline therapy. First being that maintenance has really become a standard part of treatment. We have many fewer patients that are on just observation present with advanced stage 3 or 4 ovarian cancer than what I've ever seen in my career. We have most of our patients now that are getting some form of maintenance therapy. We have 2 parts that are approved in frontline. I'll get into that in my next talk here in a moment. So we'll move to looking at PARPs in ovarian cancer. Biomarker development is critical. We are starting to see where we individualize therapy based on the molecular underpinnings of the tumor in ovarian cancer, and this is really important. We're looking at some combinations as we move forward as well, and I'll give you some of the more recent data on the immuno-oncology aspects of ovarian cancer, especially in combination PARPs with those studies that are reported out, and that's new data that we'll talk about here in a moment. But there's no question that PARP inhibitors have made a major impact. We've seen hazard ratios 0.3 less, showing over 70% reduction in progression-free survival, which we think certainly has an impact on overall survival. And we think these patients are living longer. I'll show you some curves from the PARP studies here in a little bit that I think are pretty dramatic. Frontline ovarian cancer. HIPEC continues to be revisited. I do think there's benefit to HIPEC personally, but the degree of benefit, I don't know if it's worth the hassles in the setting of all the new drugs that we have that seem to have much greater impact on hazard ratio reductions in progression-free and overall survival. But that needs to be tested, and we need to see that. We also are going to see an explosion of antibody drug conjugates moving into frontline trials. Those trials are opening here in next weeks. So I hope to next year be able to come and show you some of the preliminary results from these trials, and certainly the schematics that will then all be in the public domain, be able to share with you. A few of them are, but most of them are not. Clinical trials need to continue to occur because it's the only way we make progress. So, Shukan, thank you for listening to this first portion. In the interest of time, I'm going to move right on into PARP inhibitor therapy and where we stand with this.
As we move. Hello?
Yes, we see. Can you reshare again? Can you please reshare again?
Yes, I have to reshare. It's all one talk.
Just press the share button.
Do you see?
Not yet. Can you reshare it, please? There was a disconnection.
I didn't disconnect.
It's I think the internet quality. That's fine.
It's what? It's the same. It's the same slide deck.
Okay. It's from our side. Do share screen, please, Prof. Just press the button downstairs, down the screen. Yes. Now
you see it again. Do you see it?
Yes. Yes.
Okay. Sorry about that. Thank you. I purposely made it so we didn't have to do that. I'm sorry. Okay. So PARP inhibitors in 2026. Where do we stand? Again, same disclosures. Approaches to testing. I think that, many people have looked at maybe maybe the regulatory agencies looked at this as well. But I think that there's a misunderstanding of how many people benefit from PARP inhibitors. So if we just do germline testing, you see on the bottom, we pick up roughly 15% of our patients who are positive, right? So if we look at those who have received a mutation from either their mother or their father, so this was passed on, and this is now in the tumor that has occurred and was likely causative in contributing to the formation of the ovarian cancer. But if we look at the tumor as well, we now see an additional 5 to 7%. So now we're up over 20%. We now look at some of the homologous recombination related genes. We go up a little bit more. We're up to 35% of patients that would clearly benefit from PARP inhibition. And then when we look at genomic instability, we're now at about 50% of the patients with ovarian cancer. So it's a very large number of patients that benefit. I think that that's just something that's often lost on people who refer back to our understanding that, roughly 15% are BRCA negative. I want to remind people that we had um, major companies considering not developing PARP inhibitors, even though they had phase 2 data showing hazard ratios as low as 0.19 in BRCA carriers. Think about that. They were going to abandon this because they thought, well, the market share is so small with only 15% of a disease that's already fourth or fifth in women in terms of mortality. So is it worth that with such a small percentage? And clearly it is because the percentage is higher. But I think it's interesting to keep that in mind. I don't have time to go over the DNA pathway repairs, of which there's over five. And it's really about the fidelity of the repair that's important and how PARP fits into this with the base excision repair pathway. And then the BRCA status really affects homologous recombination. And if you don't have that intact, you switch to repair mechanisms such as non-homologous end joining and alternative end joining that do repair DNA, but they don't do so in a way that is correct to the degree that you see with homologous repair and base excision repair. So very important to understand the synthetic lethality that occurs with PARP inhibitors. So what's responsible for homologous recombination pathway repair here? And we look at this, you can see that a number of these patients have homologous recombination proficient disease, and those are the ones that we call HRP or HRD test negative. But then, as I said, 50% are in this pie graph, even slightly higher, have that defect either with BRCA or with related genes that will make PARP inhibitors more effective. And so, again, reinforcing the understanding of the underpinnings of why PARP inhibitors are effective in this disease. So, who should be tested and what testing should be performed? Personally, I think that we talked before about all ovarian cancer frontline, at a minimum, need germ cell. There's no question. But with the decrease in cost today, um, we see in testing, we're able to get tumor testing for somatic mutations that go beyond just germline and homologous recombination deficiency, whether that be from the genomic instability, which is the driving mechanism that we see in ovarian cancer, unlike prostate, where the HRR genes are more important. They're still important in ovarian, but they seem to take a second role to the genomic instability that we see with this particular cancer. And so I personally think that getting homologous recombination deficiency testing is important. And it's critical for me anyway to be able to best shape the treatment. I think the ESMO guidelines and ESGO combined are probably the most clear on that, in that the HRD tests are recommended in those with BRCA wild type disease. So what testing should you get? There's a number of different companies out there in our world. And I know there's tests designed throughout the world that have been used, as well as laboratory developed tests as well. But the genomic instability is probably the most important part of this to pick up. And the best surrogate for that is the loss of heterozygosity. So if there was only one test you had to get, that would be the best, but there are others that contribute a smaller amount, but still may be important if you're testing large volumes of patients where you'll pick up additional patients, such as the telomeric allelic imbalance or large-scale state transitions. You can, again, on the right, you see the different vendors that are available for doing that. So I promised you that we'd get into this question of immunotherapy. And I think, why it's important is that we've had a number of trials that have come out, Keylink 001, Duo, the Athena combo, and the first trial, all of which have been very well done, important trials, but many of them missed that comparator arm. And so, the big thing that we see here is that we don't have that comparator
Dr.
arm
Thomas,
that,
can you hear us?
yes,
Can you hear me?
yeah, yes.
We are not able to hear you now.
Can you hear me?
Yes, now I can.
Oh, I'm sorry. How many slides have you not heard me? Can you hear me?
Yes, Tom, we lost you for about 40 seconds.
Oh my goodness. I had no idea. Everything looked perfectly fine here. So what I was going over was the introduction of immunotherapy.
Can you please give us one second, please? You can continue now, Doctor.
Okay, thank you. I was going over the I'm getting feedback from you. Okay. Sorry about this. I don't know what's going on. I was trying to introduce the concept of immunotherapy in ovarian cancer, and I'm charged obviously with talking largely about PARP inhibitors in this particular talk, but I'm following up from my frontline maintenance talk that I just gave. And so we had a number of trials that have looked at this in the last year plus. And so I wanted to make sure that this data was out there. The bottom line on all this is some amazing trials, but I don't think they're going to change the regulatory environment very much. And that's largely in part because I don't think we have the correct comparators to allow for true proof that there's a benefit there. So while you see these curves um, are separated, when you look, for example, at arm 3 versus arm 1. What we really don't have a clear understanding is what would the PARP have done alone without the IO. And as you can see, we have in arm two, we have olaparib placebo instead of uh, doing Durva right there, and that would have been probably the better design to best understand what the contribution of durvalumab was, a PD-L1 inhibitor. So I think that has challenged all these studies to some degree because they all have slightly different designs. Some allowed Bev, some didn't allow Bev, some were very proscriptive in how the Bev was given. Others allowed physician patient to choose if they wanted to have Bev. So there's lots of differences between all these studies. This is Key Link again, showing advantages when you look at the progression-free survival based on PD-L1 expression. Um, but still challenges when you look at how does this really change things. And I think we'll still see, this came out at SGO this past year. So we'll still see some subset data, I think, that could help. The Athena combo is very clear. There was no advantage. In fact, there was a disadvantage to adding IO, in this case with rucaparib. And it actually looked like it could have done harm, perhaps in increased toxicity. And this was the data from the first trial from GSK. Again, positive data, but from a regulatory standpoint, the design is challenging to show a clear benefit of adding the IO because the PARP inhibitor is the contribution of effect is not well isolated. And so just to save time there, since we had a little break, I'll move along. But if you ask what I think the contribution will be, I think it will not be across a subset of patients. There may be a smaller subset that we find benefits from adding IO. And again, I'm talking in frontline, because as you know, we've had recent data in platinum resistant with B96 that has shown an advantage. So I don't want to confuse people. I'm talking about in the frontline setting in combination with PARP. I don't see a clear advantage for IO, but certainly worth looking at some of these subsets and what we can learn across these three trials that contribute. The Athena combo really doesn't contribute because it's very clear there was no benefit there, and again, harm. So, what are the benefits of doing BRCA testing? I've probably spent enough time on that, but it's not only prognostic, it's predictive. And it does change therapy today. So if the test changes therapy, I think it should be done, and that's why that's important. If we look at the PARP trials that have had major impact in frontline, I mentioned Athena. I didn't have it on here because from a regulatory standpoint, it has not made a big difference for us. And then you see the platinum-sensitive recurrence trials, SOLO2, Study 19, Ariel 3, and NOVA with niraparib, and the SOLO2 and Study 19 with olaparib, and Ariel 3 with rucaparib, all of which were positive trials in the platinum-sensitive setting. I wanted to bring up myelodysplastic syndrome and AML because there is an increase, but remember these patients receive quite a bit of platinum as well. So I think that's important to understand. But we see probably 6 to 7 to 8% risk of this, especially as we move this into using PARPs in those with platinum-sensitive disease. It's a bit higher. So these are the big trials in platinum-sensitive disease. And I used to show all the trials for this section, and I've totally revised this because there's been so much new data. I think the regulatory authorities throughout the globe have really pushed use of PARPs to frontline, with some reuse in those patients that escape getting PARP exposure frontline, and reuse potentially in those with long intervals to recurrence in those that have BRCA mutations. But these are our frontline or our platinum-sensitive trials that were clearly positive if you look at the hazard ratios, look at those numbers by subset. So if you look at, for example, Ariel 3 there, hazard ratio 0.23 for somatic plus HRD 0.32, and the intent to treat population 0.37. So Clearly, the most benefit in those with BRCA mutations, the second most benefit in those that are HRD test positive, and then less so for those that are HRP. We talked about frontline therapy, and these are the things that we see here that are important as we look at this. We're seeing GOG 218, Solo 1, Prima, and Palo 1 were the big trials here. In comparison, GOG 218 obviously was with bevacizumab, not with PARP, but it is important as a comparative reference as we go across here. And you can see some of the nuances here for those patients. These patients all have, in the PARP trials, received PARP after showing a response to chemotherapy, and that's important. Prima had a number of factors looking at putting filters in that really looked at patients that were high risk but had an exquisite response to platinum with having to normalize their CA-125 and so forth. And Palo 1 looked at using an active control arm with bevacizumab versus a placebo, as the other trials had done. You can see the differences here, again, in outcomes. And this was key data that shaped our adoption and regulatory approval for the PARP inhibitors, with some of the nuances there. And you can see the percentage of BRCA mutations. Solo 1 was all patients with BRCA mutations. Most of those patients had germline, a handful of them had somatic. You can see the efficacy here by subgroup. Again, remember Solo 1 was all BRCA mutated. Prima and Palo 1 were not. And you can see here the advantage in those patients that were BRCA mutated. Very impressive hazard ratio, 0.4, 0.31, 0.33. Those with no BRCA mutation but were homologous recombination deficient or deficient test positive, you can see also hazard ratios of 0.5 and less. Obviously, that did not apply to Solo 1, and it did not make a difference in 218. There was no difference in whether you were HRD positive or not based on your response to bevacizumab, based on ancillary data that was later published by Barbara Norquist. Here we look at those that are HRP, and this has been the area of contention, with Prima showing an advantage for progression-free survival of 3.7 months, which translated to a hazard ratio of 0.68. So it got an all-comers approval, whereas you did not see that because of the hazard ratio of almost 1 for those that were on Palo 1 with Bev plus olaparib versus Bev. And that resulted in some regulatory action we'll talk about in a second. I thought this was an important curve to remind you, though. Look how flat this curve is. And this, remember, the Solo 1 population was all BRCA mutated patients. But you're out now beyond 7 years, and you can see that look how many of these patients have not progressed. You can look at the PFS curves to get that, but this is the survival data from the 7-year analysis. Really incredible. Look at the medians not reached if you were on olaparib versus placebo with 75 months. So a good group, obviously, because they were BRCA mutated. So that's the prognostic part of this, but also predictive, I believe. This is looking at 5-year OS from Palo 1, looking at the combination, and then looking at Prima. Again, these curves, look at the BRCA mutated. As you get so far out, these patients don't seem to be having events. So it raises the question, can we talk about cure? I think most of you are familiar with the side effect profile for these drugs, and I've tried to simplify that into this slide here, looking at the heme effects, the non-hematologic effects, and then the more rare but significant effects that we can see from PARP, such as AML, MDS, and pneumonitis. Athena mono, we did show an advantage there in terms of looking at adding rucaparib, just as we did in others. But in the US, They have not had very good regulatory experience. I'll talk about that in a minute, but they are currently not approved in the U.S. From that data. As you know, the company Clovis went bankrupt, and then the in Primo, because we were using this in all patients. So this changed NCCN guidelines. This changed our recommendations and altered one of our publications that we had with Dr. Chan that really looked at how we should be using PARPs in frontline. So now we have surveillance or BEV in those patients with not the ability to give PARPs in the United States in those that are HRP, which is, again, 50% of our patients. So it's a large number of patients. And then you can see the extensive restriction that had occurred prior to this past year for those that had platinum sensitive or later lines of therapy, even in platinum resistant disease where we were trying to use PARPs. So to stay on time here, I want to make sure we finish on time. So maintenance therapy, largely with PARPs, have really, again, grown significantly. I have patients that we occasionally are pretty frail. I put them on surveillance, and invariably they're in a support group, and they want to know why they're the only one in the whole group that hasn't received additional therapy, when we know the chances of them recurring, approaches 70% or higher for those that present with advanced stage disease. And so majority of my patients are on some type of maintenance therapy at this point for frontline ovarian advanced cancer. Combinations we talked about. So you have the combination of BEV plus PARP, and then we did talk about some of the triplet combinations with the incorporation of an IO, which, as I said, in the United States, I think with the current data, we're probably not going to see a full FDA approval in those settings, and we have to think about cost and true value that comes with that. But there may be a subset yet where that story changes, so stay tuned for that. I do think PARP inhibitors have totally transformed frontline ovarian cancer landscape, and I'm personally hopeful that we're curing more patients with ovarian cancer. So I think that's important. I do want to remind everyone from both talks that surgery and maximum removal of disease with cytoreduction is incredibly important. I talked about the regulatory path for IO and PARP, at least in the US. And the recent FDA decisions have really pushed PARP use to frontline. So it's not one of those situations where I hear some clinicians say we should save it for later in case we need it. No, time to use it is upfront. You'll get the most gain because a hazard ratio of, say, 0.3 purchases so many more months in the frontline setting than it does in the recurrent setting. And it's more difficult to get from a regulatory standpoint as well. But we're now limited in frontline to only those with homologous recombination deficiency test negative. So I want to thank everyone. I know that's a lot of material. Again, I'll share the slides and be available for questions after the next talk here. Shukran leka.
Keep the questions till the end after the talk of Professor Mohsen Mukhtar. Now we have Professor Mohsen Mukhtar. He is beyond any introduction. He's professor of clinical oncology at Cairo University, and he's managing the director of Cairo University Center of Oncology and Nuclear Medicine, NIMROC. Also, he's the president of the Can Survive Association. Welcome, Prof. Mohsen. His talk will cover the recurrent ovarian cancer.
Thank you very much, Mr. Chairman, Dr. Ahmed, Dr. Hatem. Shukran alaikum. I'd like to extend my
great sincere thanks to Professor Ishmael for inviting me. It's always an honor to be here with you as part of this masterclass. It's actually my first, but hopefully not my last. Impressive talks by Professor Herzog on how frontline therapy for ovarian cancer has changed, and we are definitely, as he said, doing much better than we were in years before. But the unfortunate thing that he also showed us is that a good portion of our patients will at some point have a recurrence. And when you do get those patients in your clinic as a treating gyne-oncologist, you obviously dread that day because you know that you don't really have much to offer these patients, and it's actually quite dismal. But I think that is really changing, and as we will be showing you, there's robust data on how we are changing that. We are probably, hopefully, going to improve the survival of these patients. So these are my disclosures, and we define our patients when they have a recurrence as platinum sensitive and platinum resistant, and that's according to the 6-month cutoff point from the last progression after the last platinum that they had. So is it the 6-month platinum-free interval or less than 6 months? And that's how we're defining that. So if you look at platinum-sensitive recurrent ovarian cancer, what you're seeing is that is there any role for surgery? And this is if we've got any of our surgeons with us here. Is there a role for surgery in recurrent ovarian cancer? And I think it is case by case, because if you look at the ESMO guidelines, they will tell you that if it is the first time of recurrence and you've got an AGO score that is good or positive, then you should consider going in for surgery. And we've got some sort of conflicting data between different trials. We've got 3 trials. The GOG 213 that showed no progression-free survival or overall survival benefit. Then we had the desktop that showed both progression-free survival and overall survival benefit, and the SOC1 progression-free survival positive, and a trend towards overall survival. And I think, again, it is case by case. What is the performance status of that patient? What is the amount of ascites? And who is the surgeon at hand with you, and can he have an R0 resection? Because if you're not going to do an R0 resection for that patient, then there is no benefit of the surgery. But moving on to systemic therapy, if we look at the data we have on chemotherapy, whether it's a single agent or a doublet chemotherapy, or even with the addition of bevacizumab according to the Aurelia trial, what we are seeing is that we do get good responses in these patients. These patients actually respond, and you're looking at responses between 50, even up to 80%, and a progression-free survival that is in the range of around 9 to 12 months, and a median overall survival that is actually quite good. So platinum-sensitive patients, yes, they do benefit from chemotherapy. Then we had Professor Herzog gave us hints on study 19 and as well as the solo. Study 19 was maintenance for all patients who were platinum sensitive, regardless of their BRCA mutation, olaparib versus a placebo. And what we see here is that if you look at the progression-free survival, you are getting a hazard ratio of 0.35 with a median progression-free survival of around 8.4 months, and nearly doubling that of the placebo. So it is something worthy if your patient had not received a PARP inhibitor, even if they are not HRD or BRCA mutated, but do have a platinum sensitive relapse, then a PARP inhibitor is worth it for these patients. And you can see from the overall survival, the hazard ratio 0.73, even though the curves look, or the numbers look similar, 27 and 29, but you do stick to that hazard ratio of 0.73. So an absolute benefit of 27%, even though 13% of the patients who were on the placebo arm went in and received the PARP inhibitor later on in their lines. The solo 2 data was with the patients with a BRCA mutation, previous 2 lines of therapy, responding to a platinum-based therapy, olaparib versus placebo, 2-to-1 randomization. Again, looking at progression-free survival and overall survival for these patients. I know we've got excellent talks coming up on PARP inhibitors, so I won't dwell much into it. But just to show you that the overall survival was beaten by around 13 months with the use of olaparib in these patients, hazard ratio of 0.74. And if you look at 6 years, 42% of the patients were still alive in this trial. So again, if your patient had not used a PARP inhibitor for whatever reason and is platinum sensitive, then again, you might be challenged. Now the question comes up with, if your patient had used a PARP inhibitor in the initial frontline therapy, can you re-challenge with a PARP inhibitor? And the answer is we do not have proper data for that. But again, it would be case by case and how long she had progressed after ending the initial PARP inhibitor for her frontline therapy. Immunotherapy for platinum-sensitive ovarian cancer has been tested out. The Atlantic data here, 1 to 2 lines of prior chemotherapy, platinum-free interval more than 6 months, carboplatin-based therapy with BEV plus atezolizumab versus the similar combination, but without the atezolizumab, looking at progression-free survival as well as overall survival. Now, the initial data on this was that the progression-free survival hazard ratio was 0.88, so there was no benefit for the addition of atezolizumab. But then in the update from the ESMO, what they showed was that at 5 years, the overall survival, there was a 10% benefit. So this was not valued statistically because you have a negative primary endpoint, which was the progression-free survival. So there was no statistics for the overall survival endpoint. But what it does tell you is that this is something worth pursuing in further clinical data or clinical trials. But till today, this is considered as a negative trial. So there is no use for any immunotherapy in platinum-sensitive labs. What about ADCs? Dr. Herzog, renowned for that, or hinted to this. And what he said was in platinum-sensitive patients, the PICLO trial, here again, patients had to have folate receptor alpha positive, more than 75%, with an immunohistochemistry staining of 2+ or more. Mirvetuximab was tested out in this single-arm phase 2 trial. Patients had to have at least 2 prior lines of platinum-based regimen, prior PARP inhibitor, if BRCA positive, and prior BEV was not required. Mirvetuximab at 6 milligrams, looking at overall response rate and duration of response, as well as progression-free survival and safety. Now, I'm putting this patient demographics for several reasons. One, 25% of these patients have received a PARP inhibitor. And that is really important because as we've heard from Professor Herzog, the good majority of our patients, whether HRD or BRCA mutated, will have received a PARP inhibitor initially. So when they do have a recurrence, this is one of the things to look forward. You're looking at BRCA mutation in 25% of the patients. PARP inhibitor was given actually in 81% of the patients priorly, and prior exposure to that was seen in around 64% of the patients. Well balanced between less than 12 months and more than 12 months, but obviously all more than 6 months after recurrence. This was the final overall survival that was presented in the last ESMO, 27.17 months for all these for all the patients. And one of the things that I wanted to take you to was this. If your patient is PARP naive, your progression-free survival is 10 months as compared to patients who receive prior PARP. Obviously, they all do respond. The response is higher in patients who are PARP naive, less so in patients who had prior PARP or had progressed on a PARP inhibitor, but you ended up in the end, all of them have an overall survival of around 27 months in data coming out from this trial. Now, does it matter whether your patient is HRD positive or negative? Again, here from the curves, clearly no difference whether the patient is HRD positive or negative. Though your HRD positive patients have an overall response that is higher than the HRD negative, but the duration of response in the HRD negative patients is actually higher than that of the HRD positive. The more challenging question, and the one that we all pull our hair out, unfortunately I don't have any hair to pull out anymore, but anyway, when you get a patient with a platinum-resistant ovarian cancer, and that is really one of the challenging cases that you can face in your clinic. Chemotherapy, rightly so, gave you anything of a response of around, in the end, something around 15%. Median progression as chemotherapy, even with BEV, you are looking at a progression of around 5 months. And an overall survival that is generally less than 12 months for these patients, with a lot of side effects coming out from these chemotherapies and limited prognosis for these patients. So what has changed? Can we give a PARP inhibitor in a patient that is platinum resistant? And I put up this trial specifically because the NRGs took cediranib, which is a multi-tyrosine kinase inhibitor, against mainly masculine growth factors with c-KIT and platelet-derived growth factor, plus minus olaparib. This trial is considered as negative, but what I wanted you to focus on is that line where olaparib plus cediranib, if you look at the progression-free survival, 5.2, median overall survival is actually less than the standard of care. So there is still today no role of using a PARP inhibitor in a patient that is platinum resistant or has progressed on a platinum-based therapy. Now, the next kids on the block, and the exciting data, and please bear because there is a lot of data, and there's a lot of data that came out actually in the past couple of years. So there is a lot of names of drugs. So overwhelmed as I was overwhelmed when I was doing this. So several biomarkers directed ADCs, that smart chemotherapy, the payload, the linker, and the target are what make each ADC unique. So you've got ADCs for folate receptor alpha, HER2, cadherin 6. We've also got TROP2, and then a couple of others that were presented in the ESMO, like NaPi2. And then you have other things like relacorilant, which is a glucocorticoid receptor antagonist, not an ADC. And then you've got immunotherapy for these patients, and namely positive trial, as Dr. Herzog was saying, on the B96 trial. I put up this trial even though it was negative, just to show you that not all immunotherapy is the same. Here, the NGOT 034 tested out atezolizumab with pegylated liposomal doxorubicin or paclitaxel plus bevacizumab versus the same combination but without the atezolizumab. 550 patients looking at overall survival, progression-free survival in the intent to treat population. And what we see here is that no benefit whatsoever from the addition of atezolizumab. 6.4 months progression-free survival versus 6.7 for the placebo, hazard ratio 0.87, and in terms of overall survival, hazard ratio exactly the same, 0.83, even though we do have a benefit, slight benefit of around 1 month for these patients. Then we had the more exciting data that came out from the last ESMO, the B96 trial. So these were patients who were ovarian, fallopian tube, or primary peritoneal carcinoma, 1 to 2 lines of prior therapy, platinum-based therapy 1, prior anti-PD-1 or anti-PD-L1 was actually allowed, PARP inhibitors were allowed, and BEV was also allowed in this trial. So these are your classic patients after progressing on therapy. And they were looking at BEV, stratifying them according to the use of BEV or not, and so the paclitaxel on days 1, 8, and 15, plus or minus bevacizumab versus the same combination without the pembrolizumab. Now, if you look at several things, objective response, and this is again really important for patients with ovarian cancer. As you know, a lot of them will have some sort of unstableness in the GI. Response is really important for these patients. We see that the delta for the benefit for the additional pembrolizumab was 5.8, going up to 50% in the CVS more than 1. And in terms of duration of response, at 18 months, you have a difference of 14% for these patients. What about the patients in the whole group of patients, the intent to treat? Yes, the overall response rate goes down to 50 as compared to 3, but the delta even gets higher at 8.9. And at 18 months, you have that benefit of 12% in terms of duration of response. to a progression-free survival, both in the CPS more than one and in the intent to treat populations so presented. In the ESMO, we're seeing hazard ratio of 0.75 and 0.73 respectively. So in both groups of patients, whether CPS positive or in the whole intent group population, you do have a benefit of progression-free survival. This was also presented at the ESMO that the overall survival in the CPS group was met with a hazard ratio of 0.76, and we're seeing a 4-month benefit in terms of overall survival for these patients with the addition of pembrolizumab. We've also had a press release that in the intent to treat population, it has also been met in terms of overall survival, though we do not have yet the full data on the whole group of patients. Shifting to ADCs, we're going to have a talk by Professor Walid on mirvetuximab. But again, just to get you into the ADC groups, the MIRASOL trial with mirvetuximab in platinum-resistant patients, following on the Soraya trial, here folate receptor alpha with 2+ in more than 75% of the patients. And please remember that 2+ in 75% of the patients, platinum refractory were not allowed. And this is a new term that we're going to see in several trials. So the patients who progressed within less than 3 months are now considered as out of these clinical trials. So you'll have a window of platinum resistance after 3 months and less than 6 months. Prior BEV and PARP inhibitor were allowed. Again, a classic patient as one of our patients. Mirvetuximab versus chemotherapy, looking at progression-free survival, overall response rate, and overall survival. It met its overall survival with a hazard ratio of 0.67, and again, a 4-month benefit. And always remember that 4-month benefit in recurrent platinum-resistant ovarian carcinoma. That's not the only ADC against the folate receptor alpha. We have the rainfall data with Rina-S or rinatabart sesutecan. Again, this has a different payload. So this is a topo-1 isomerase inhibitor. Here, Rina-S was tested out in 2 doses, 100 milligrams per kg versus 120 milligrams per kg. Response rates are very high in the range of 55%, specifically in the 120 milligrams. And if you look at the response rate, it's actually regardless of the folate receptor alpha expression. So less than 75% or more than 75%. If you're looking at adverse events, I'm sure we're going to hear all about the adverse events from mirvetuximab. Here with the Rina-S, you do have the same cytopenias as well as GI toxicities. However, there are no ocular toxicities, no neuropathy, or ILD was observed with rinatabart in this trial. That is not the last of the folate receptor alpha ADCs. The Fontana, again, in the last ESMO with the AZD535 drug. Recurrent platinum-resistant ovarian, they initially started on patients with no selection for the folate receptor. Then they added on another 124 patients, but here they wanted patients with folate receptor alpha more than 75% with an immunohistochemistry IHC score of 1+, so less than that of the mirvetuximab. The patients, 189 patients, prior BEV and prior PARP seen in the majority of patients. The overall response rate in this data is 53.6. The next one in the folate receptor alpha ADCs, and I think probably if anyone's going to put any money, put it on this one because L46 has received mirvetuximab, and this is the first hint that we are getting of sequencing of ADCs in ovarian cancer. And here we see that the response rate is 50% and the disease rate 78% in these patients. Again, waiting for a full phase 3 from this drug. Shifting to the next target with an ADC, which is cadherin-6. This is data from the REJOICE trial. The REJOICE trial used RDXD in patients with ovarian and endometrioid ovarian cancer, serous or endometrioid ovarian cancer. They started out with 4 doses. Actually, 8 was the maximum dose, and then they omitted the 8 milligrams per kg and stuck to the 4.8, 5.6, or 6.4. So 3 doses were tested out. They ended up with the 5.6. This was the expression of cadherin 6 is actually overexpressed or observed in around 65 to 85% of patients with epithelial tumors. However, in this trial, it was observed also that regardless of the cadherin expression, these patients do respond to RDNXD. So if you look at, this was the patient's deposition, and again, just to show you, progressive disease was only seen in 24% of these patients. And if you look at the response rate, highest with the 5 points, with the 6.4. However, if you look at the duration of response or disease control rate, was actually highest with the 5.6. Nausea, anemia, asthenia, and neutropenia are the commonest side effects. And what we're seeing is that the part 3 or the full phase 3 data from the Rejoice ovarian 1 will come with data having 5.6 milligrams per kg.
1 minute, that's all.
Sorry. We have the HER2, and as you can see here with the DESMI, TXD, we're seeing IC63 plus, and if you look at TROP2, again with Dato-DXd, 35 patients, we're looking at very good response, specifically in the platinum sensitive. That is not the only one. SAC-TMT, another TROP2 inhibitor, ADC, overall response rate was 40%, disease control rate 75%, and the median survival of 16 months. Napistar and as well as others are being tested out in terms of ADCs, and this is a full list of those coming out from the ESMO. Then if you shift gears from the clinical trials with ADCs, we are going to look at Rosella trial. This is relacorilant, which is an antibody antagonist against the glucocorticoid receptor, blocking the cortisol interaction with that glucocorticoid receptor. And from that, this will allow the chemotherapy to act better and cause more apoptosis. The data from the Rosella trial showed you hazard ratios of 0.7 and 0.69 in progression-free survival and overall survival. And if you look at the PARP inhibitor, if the patient had PARP inhibitor prior or progressed on PARP inhibitor, again, you do have a benefit in PFS. It's actually quite a safe drug, whether or not the patient had received a PARP inhibitor before. So as a closing remark, obviously recurrent ovarian cancer treatment is challenging. MDT probably in the beginning, definitely with a surgeon, so that if these patients can go on for surgery. MDT to look at biomarkers as well as genetic profiling for your patient is always a must. The role of ADCs, checkpoint inhibitors, and an antagonist like the glucocorticoid antagonist is growing. The sequence is not yet defined, and will it depend on the genetic profiling, the efficacy, or the adverse events? Actually, it probably will depend on a combination of all of these, and not forgetting the price of all these medications and what it does to the economy. Thank you very much for your attention.
Thank you. Thank you, Professor Mohsen, for the nice presentation. And just join us here for the discussion. We have 5 minutes for discussion. Prof. Mohsen, if you can join us.
If you can join us for this time, we will have maybe 7 minutes for discussion because, I mean, please. So,
Okay, I may start with the question to the audience. For Prof. Mohsen, which patient is the best candidate for surgery in the recurrent setting? Which patient will you refer for surgery?
So the patient for surgery at recurrence, probably the one that has a very good performance status, has a long time out of being from the initial therapy or initial surgery, and a patient that has very minimal ascites, as well as having a surgeon that will tell you that this patient can go in for an R0 resection. If there is no possibility for an R0 resection, then I don't believe that there is any benefit for these patients.
Thank you. Any questions? Yeah.
Yeah, thanks, Prof. Herzog, for your presentation. And I would like to ask regarding the last update from the FDA for the restriction for niraparib. Why it's the FDA restricted in June 2025, not it's before, and since presented the data of the overall survival data in the ESMO in 2024. Why they wait for this long time? And what's it? This is secondary endpoint overall survival. Is this reasonable to restrict the HRD using the niraparib and non-HRD in this population, since the overall survival is secondary endpoint, not designed to calculate the overall survival?
Yeah, thank you. That's a wonderful question. What took so long, and B, what parameters were they looking at? I think that there was a lot of back and forth, that they asked for additional data, and those things take weeks to months to get back and forth and so on. So it took some time. I personally don't agree with what happened, because what they were looking at were non-analytic populations that were a subset. And so these patients didn't have enough alpha powered to look at this. In fact, the studies weren't powered for full OS assessment. There was alpha assigned to them. They were analytic as a group, but when you break it down by subgroups such as HRP and HRD, when you start breaking them into the different molecular subgroups, which is what they tried to do, they're making decisions that I think are not statistically founded. So if you look at the overall, the hazard ratio for OS was 1.01. How can you say there's a detriment in OS with that remarkable gain in progression-free survival when you have a hazard ratio of 1.01? What they did look at was the subgroup that was unknown, and that was a hazard ratio of 1.31. And I think that was a group that was of concern, but who are those patients and why were they unknown in terms of their HRD status? When the protocol had called for testing, was there insufficient tissue? What was going on there? And so there's a lot of confusion as to what happened here. I don't think all regulatory agencies are going to see it the same way as we've seen in Europe. And so we'll see what happens. But I personally don't disagree that the greatest benefit is in those that are HRD positive. But the test as we currently have them are too imperfect to exclude some patients that still benefit that were in the HRP population, as the data showed.
Prof. Thomas, do you think that the high-risk group included in the PRIMA trial may be the main cause of the negativity of overall survival?
I don't think so, because I don't see the negative overall survival. Overall, it was 1.01. If you look in the ones that were known, it was below 1. It was 0.93, 0.95. So that doesn't fit. And then if you look at corroborative evidence from the Chinese data as well as Athena mono, it appears that data is trending positive as well, with some patients that are benefiting. So certainly no detriment in OS, which is what I think the agency is trying to claim. I personally think, and this is just me, I personally think that they're trying to sort of put all these PARPs together as a class effect. And since they said, well, we did this with olaparib, we're going to do this with niraparib. That's my personal opinion, because I've heard some rhetoric from some of the agency that has represented that there's a class effect with these PARPs, and they don't think there's a big difference.
Thank you. Any other questions? We have just last question about the HIPEC. Now, after 10 years of follow-up of the OV HIPEC trial, which showed clearly in stage 3 recruited patient that there is overall survival and PFS also. Do you think that HIPEC, whenever available in some centers, should be standard of care for or at least stage 3 patient?
I think that there's still conflicting evidence out there. I'm hoping the GOG 3068 trial is able to answer this more fully, addressing some of the questions that were present in some of the other trials. I don't fault anyone for offering this. I think the benefits are probably going to be in the range of, 0.7 or higher in terms of the hazard ratio. How that'll fit in with all the new drugs we have, which have hazard ratios much less, remains to be seen. So, do I think HIPEC's an effective tool in some patients? Yes. Do I think it's effective in all patients? No. Do we need more data to say it's the standard of care? I think so. And so for now, I prefer personally to offer it on trial, and we certainly have that option open at our institution now. So we do offer HIPEC, but through a clinical trial.
Thank you very much, Tom, and thank you very much, Professor. This concludes the first session. In order for the sake of the time, we'll move for the next session now.
Assalamu alaikum wa rahmatullahi wa barakatuh. Thank you, Dr. Nashmiya, for the continued masterclass of the Gyne. One of the best meetings we attend the national level is that meetings, and this is now is 11 years of cooperation of these meetings. And thank you again for all the team and the scientific committee. It's my great pleasure. Thank you for the AstraZeneca for Satellite Symposium. And just to continue what we have in the ovarian cancer, the first session is nice, excellent talk regarding ovarian cancer, the first line setting and the recurrent setting by Prof. Mukhtar and Prof. Toms. Now we are moving for Satellite Symposium by Dr. Mohammed Saifan. He is well-known consultant medical oncology at Security Force Hospital. He will talk about PAOLA-1 protocol, how is the precision medicine to select for patient with ovarian cancer in the first line setting.
Assalamu alaikum. Good afternoon, everyone. Jum'ah Mubarak. First, I would like to thank Dr. Nashmiya for her successful consecutive meeting for the 11th time so far. And I would like to thank Dr. Walid for his kind introduction. Actually, Prof. Thomas Herzog made my job easier explaining all the data about frontline and PARP inhibitor. However, I'm going to discuss the role of PAOLA-1, which is a milestone as a precision medicine for first-line maintenance. So this is my disclosure agenda. So first, we all know that bevacizumab as an induction and maintenance was initially found in GOG 218 and ICON 7. And as PFS was seen for the entire group, however, overall survival was only noted in those with high-risk population, stage 4 or with a significant residual disease, ascites, etc. So since bevacizumab works mainly in this population, the question that needed to be answered is for how long and what is the appropriate dose when we are considering bevacizumab. And from ENGOT OV15, we have learned that 22 cycle or 15 month is as good as 30 cycle of 30 month of bevacizumab, and at a dose of 15 milligram per kg. And that's why we see that in PAOLA-1, we have 15 month of bevacizumab at that dose. So, and you see no difference when we compare both groups. So K-lemon score is something that we always talk about. However, we don't really use it in the clinic. However, K-lemon score is the elimination constant for CA12-5. It's actually a measurement of 3 consecutive readings of CA12-5, and it gives you either a favorable versus unfavorable. You do see in green and the black. The unfavorable group is the subset of patients who actually benefits from bevacizumab, whereas in red and blue, you see that the favorable group does not really benefit from adding bevacizumab to the equation. This was also validated from GOG 218, and with not only PFS advantage, but as well as overall survival. And there is actually a calculator that you can always use in the internet to calculate the KLM score. So epithelial ovarian cancer is, when we talk about HRD, it actually represents more than 50%. 30% of those are germline and somatic BRCA alterations. The remaining are the other HRR pathway that results in genomic instability. So there are two ways of doing repair, either HRR by homologous recombination repair, which is the most accurate way. It's slow, but it is the most accurate and to repairing single and double-stranded breaks. However, if we have any alteration or any deficiency in homologous recombination repair, we use non-homologous end joining, which is fast, however, error prone, and that's what we see when we have this alteration. So this is the theory behind using PARP inhibitor in ovarian cancer. And we did see how the landscape of ovarian cancer have evolved from 2011 till today. So bevacizumab role was initially seen in both GOG-218 and ICON-7. However, their approval from EMA till and to be adopted in the US, it took around 7 years, which is due to the fact that it had only PFS, and only in the subgroup analysis we did see the overall survival advantage, similar to what we see now when we dissect PARP inhibitors across different subgroups. So I'm gonna start my talk with addressing PARP inhibitor in the frontline maintenance. And I'll start with the SOLO-1, which was the first study to assess a PARP inhibitor as a first-line maintenance. So SOLO-1 did include patients with advanced either stage 3 or stage 4 endometrioid or high-grade serous. They all had to have BRCA mutation and good performance status. The randomization was to olaparib versus placebo, and with the primary endpoint of PFS. One important point to highlight is that the duration of olaparib here is unlike niraparib, it's only 2 years, and they did allow an additional year upon the physician discretion. So if you look into platinum sensitivity, because these patients were allowed if they actually achieve CR or PR. So majority did have an excellent complete response, which is expected because those are a population of BRCA mutation. So they are platinum sensitive in theory. So this is the primary interim analysis and secondary interim analysis. We see that PFS for this BRCA mutated patients actually triples from 13 months to 56 months, with a reduction in risk of progression by 67%. So how about overall survival? So we are now around like 8 years or more at 7 years of follow-up. We do see the curves, despite stopping olaparib after 2 years, continues to separate even further, with the median overall survival being still not reached, with a reduction in risk of death by 45%. And this is despite the fact that the control arm, they were allowed to cross over, and almost 44% of those did receive any kind of PARP inhibition in later lines. So not only PFS, overall survival, time to first subsequent line of therapy, time to second subsequent line of therapy, they were all in favor of olaparib in the first line maintenance. So switching gears to another PARP inhibitor. However, here in the PRIMA trial, they were more generous. They did accept all intent to treat, so not only BRCA or HRD. They took all comers, and they had a similar inclusion of advanced high-grade serous or endometrioid. They had to achieve, again, similar to SOLO-1, CR or PR to first-line platinum combination. And if you look into their baseline characteristic, majority of these patients had residual, more than 90%, which is strange. However, the duration of niraparib was for 3 years, unlike olaparib, which was only for 2 years. With the primary endpoint, similar to SOLO-1, was PFS by blinded independent central review. So if we look into the most, the first report, you'd see that the intent to treat and bank as well as HRD, they all benefited from giving niraparib as a maintenance. However, if we dissect these population at the final analysis that was presented 2 years ago, you'll see that PFS benefit was there with a delta of almost 10% in favor of maintenance niraparib. If you look into HRD, the benefit is even bigger, doubling, almost doubling of PFS from 16 to 35. However, look at HRB. I think we say, why was this revoked by FDA? I think yes, we see a benefit in PFS. However, the benefit is short-lived. For some population, this might be applied, but there isn't really something special about niraparib. If you get that, you'll see actually a similar Kaplan-Meier as we see here in niraparib. So final overall survival was really disappointing. Everyone in the room in ESMO was disappointed. You see curves on top of each other. Prof. Antonio tried to come with explanation, why could this happen, the poor subgroup, or is it the crossover to PARP inhibitor? However, you guys will see that even in PAOLA-1, almost similar percentage have actually crossed over from the control arm to receive another subsequent PARP inhibitor. So it doesn't really explain the reason why OS was negative in that study. If you look intention to treat HRD, HRB, they were all negative or not negative. You'd see them actually on top of each other. So you don't see that OS advantage when you use niraparib for this population. So coming to rucaparib, which was studied in Athena mono and Athena combo. However, I'm not going to discuss Athena combo as it was negative. Athena mono did assess a maintenance rucaparib similar to PRIMA. However, they didn't use the same testing that was done in SOLO or PAOLA or PRIMA. They actually looked into loss of heterogeneity. And the benefit was there, the exact same thing that we see with the PRIMA. You see here the benefit in the intent to treat BRCA mutated, BRCA wild type, as well as HRB, which are considered here LOH low. So coming to PAOLA-1, PAOLA-1 is the first study to compare itself, this combination of olaparib plus bevacizumab, with an active competitor arm, which is bevacizumab, which we all have seen their approval and the evidence behind it. So PAOLA-1 have studied the exact same population of advanced stage 3 and 4 ovarian or the primary peritoneal disease. They did allow primary versus interval debulking, and you'll see that in the baseline characteristic, there was almost 10% who did not receive any kind of surgery. The randomization was for olaparib for 2 years plus bevacizumab for 15 months, as we have seen from the ENGOT study, versus placebo plus bevacizumab. And again, similar to SOLO-1, they did allow an additional year of olaparib upon physician discretion. And here the primary endpoint was BFS by investigator assessed. So if you look here, you'll see that almost 50% they went for upfront or primary debulking versus interval. No surgery was there in 7 to 8%. As here, we are not talking about restricted to BRCA mutated patients. You'll see that the rate of no evidence disease or CR is less than what we see with SOLO-1. This is the explanation, because not all of them are actually HRD or BRCA mutated patients. So if you look into the primary endpoint of PFS, as expected, on the left, you see BRCA having the highest magnitude of benefit with a hazard ratio of 0.53. However, if you look into the middle one, you'll see again significant benefit. However, this is for HRD excluding BRCA, and with a hazard ratio of 0.43. If you look into HRD negative, you'll see that actually hazard ratio of 0.9, curves on top of each other, which tells you that bevacizumab is actually working in this population, and adding BARP to the equation does not yield in any better improvement. So if we look into PFS for the HRD, including both BRCA and non-BRCA, you'll see that the hazard ratio is actually 0.41, and the median PFS have improved from 17 to almost 50 months, which is again almost 3 times the median PFS that we get with bevacizumab alone. So how about overall survival? So at 5 years, if you look into the intent to treat, OS is actually negative. However, focusing on OS for the HRD positive population, whether BRCA or non-BRCA, you see a delta of almost 17% in favor of Paula regimen. And this translates to a 1.5 year improvement in overall survival over bevacizumab alone in the control arm, with a reduction in risk of death by 38%. And here again, you do see, similar to PRIMA, almost 38% crossover rate. So that's why we cannot really explain the absence of OS in PRIMA, which is actually seen here in Paula 1. So looking into the subgroups, BRCA mutated patients had a delta of 20%, hazard ratio of 0.6. If we look into HRD excluding BRCA, which is actually not present, this kind of analysis was not there for PRIMA because they give you only HRD. Here we are showing you the worst population, which are HRD, however, non-BRCA. So you don't expect that if you add BRCA to this population, the outcome would be even better. But here you see the hazard ratio of 0.71. Yes, not statistically significant, crossing the 1, but the curves speak for themselves. You see them separated. HRD negative, again, no added value. So one important point when Paula 1 was started or presented is to whom should we apply Paula 1? Is it only for those with high risk stage 4 ascites, as we have seen from GOG 218? But you'd be surprised that Paula 1 analysis you'd see even a better benefit for those with low risk population. The benefit is there for everyone, but more for the low. And if you look into HRD versus non-HRD, again, you'll see that those with lower risk also had a better benefit than non-low risk. Adverse event of special interest. So we know that AML, MDS, and pneumonitis is the toxicity of special interest. However, it wasn't really, we don't see any safety concern when we use this combination, almost similar rate of these adverse events. So now to answer this question clearly, should we go for a PARP or should we go for a PARP combination with bevacizumab? So we don't have a perfect evidence to answer this question, and we will never have. However, if we look into a matched indirect comparison of Paula versus Solo, and here we are comparing olaparib alone versus olaparib plus bev for a similar patient population, you'll see that in the green curve, BFS was actually better in favor of the combination. Moving on. So how about maybe olaparib is not as good as niraparib? So we will answer this again by an indirect match comparison, addressing the similar patient characteristic population from both of these studies. And the answer is, in the pink or in the purple, olaparib did better in terms of PFS. You do see that bev alone from the control of Paula, as well as PRIMA with niraparib, kind of cross, however, numerically wasn't better in favor of niraparib for the PFS. If we go over those with the BRCA or HRD positive, again, you see the magnitude of benefit for the combination is better, almost 3 years of median PFS, followed by niraparib 22 months, followed by bev alone with 17.6 months. So another thing that actually solidified this theory of combination being better, this is Avanova 2 trial, which have been addressing a chemo-free regimen for platinum sensitive. So you wouldn't give any kind of platinum. They have asked this question to give niraparib alone or niraparib plus bevacizumab till disease progression, with the primary endpoint of PFS. And the answer is combo is better. You can see this clearly with a hazard ratio of 0.35 And when you look into different subgroups, whether BRCA or non-BRCA, actually BRCA wild type did better. You see this, it's not really that PARP is better or not, but it seems the combination is actually synergetic for this population. And from this platinum sensitive data, GSK is actually pursuing a study in the first line maintenance for only stage 3, no stage 4, to use either niraparib as a combination, as a maintenance, or niraparib plus bevacizumab. So in theory, combination is more efficacious or synergetic, in my opinion, and even meta-analysis that was recently published addressing first-line maintenance, you'll see that the conclusion was in advanced epithelial ovarian cancer, regardless of the subgroup, the combination with PARP plus chemo plus and or angiogenic was better than giving monotherapy maintenance. So in summary, and I have actually updated this with the last version of NCCN. So what should we use for BRCA-associated cancer? The answer is we can use all kind of PARP. Do we actually need to add bevacizumab or not? I think if you believe that combination is synergetic, you should do so, unless there is any contraindication to give bevacizumab. So how about HRD positive? In HRD positive, the preferred option, in my opinion, as well as NCCN, is actually PAOLA-1 regimen, as it is category 1 evidence. However, if you are unable to use bevacizumab, then you can actually choose any one of the PARP available, olaparib, niraparib, or rucaparib. HRB, bevacizumab work. I used to add niraparib there. I still believe that niraparib is a considerable option for patients who are Bev non-candidate and they are not, or even if they are Bev candidate and they live away from a hospital. It should be an option just based on PFS. However, if it's either BEV or no maintenance, as per the last guidelines, NCCN guidelines. So how would I see my patients in the clinic? The first question I need to answer, or actually my oncologist needs to answer, is it going to be a primary or an interval debulking? If you answer this, the second question will be, am I going to use bevacizumab or not? Is there any contraindication? And accordingly, if there is no BEV, let's finish. If the patient is no BEV candidate, BRCA, then you have solo one evidence, or you do have the evidence from PRIMA and Datina mono. You can use any of those. If it is an HRB, the current preferred option is actually observation. If you're not going to give bevacizumab, and again, you can actually give niraparib for a subset of patients. So how about those whom are BEV candidate? If they are BRCA or HRD, level 1 evidence is actually in favor of PAOLA-1, despite NCCN statement, if your patients cannot tolerate olaparib, you may substitute olaparib with niraparib in this situation. Those with HRB, the current evidence stays with the GOG-218 and by giving only bevacizumab maintenance alone. And this is actually the summary of what you guys see here from the latest version of NCCN. Hematological toxicity have been already addressed. It's mainly hematological. We do see unique non-hematological, such as LFT with rucaparib more. And the rare toxicity of all of these PARP inhibitors is AML, MDS, and pneumonitis. So my take-home messages is that bevacizumab maintenance did show a better PFS and possibly OS advantage, especially for high-risk population. PARP inhibitors, again, did show a significant and clinical meaningful overall survival advantage in the BRCA mutation, HRD positive, and to a lesser extent in those with HRB. Bevacizumab combination, when added to olaparib from PAOLA-1, did show a PFS and overall survival advantage for the HRD positive patients, low and high risk. And the treatment decision should be guided according to bevacizumab eligibility, BRCA or HRD status, and lastly, patient preference. And with that, I conclude. Thank you.
Thank you, Mohammed. Excellent talk.
clearly, Mohammed, for those patients with BRCA positive patients, thinking the PARP inhibitors is enough can do the job for those patients. But again, for the patient with now, you are clearly seeing that in the solo one and Paula one for patients with BRCA positive, HRD positive patients. Again, the combo is more of the combo in the HRD positive patients. That's clearly benefit. If patients, I get one of the questions, that's how is those patients with BRCA mutated patients and HRD positive can be, again, olaparib alone is working, or we should be combined both. We know that the benefit is more with combo. But again, if she has asked about the quality of life regarding the bevacizumab.
So I think from data, meta-analysis, and direct comparison, combo did prove its superiority. So the way I do it, patients who lives in Riyadh and they are actually okay coming to receive bevacizumab because it's not going to be like 22 cycles.
Yeah.
It's going to be the remaining after the initial 6 cycles, which is around 15, 16. So patients from Riyadh, I actually give them combo and I explain the superiority. Patients from outside Riyadh, I explain both options. However, being olaparib alone have shown a significant benefit can be enough for these patients if they are away or for any reason if they refuse bevacizumab as a maintenance.
Yeah, we just discussed before with Mohammed Roysan regarding the choice of using bevacizumab. It is a consider. Usually, we start in the neoadjuvant setting. Some of those patients the chemotherapy plus bevacizumab. That is not a common practice, but some of those patients, especially with have huge ascites and have pleural effusions, to start with confirm that is a malignant disease, and then we'll start that the bevacizumab plus chemotherapy, and then consider that patient came HRD. That's easy to continue with Paula protocol. But for those patients, he came and he has wild type, BRCA negative, HRD negative, and the questions Muhammad is those patients still have now can be considering no maintenance therapy for some of those patients, no maintenance. And personally, I'm not doing that. Most of our patients he need maintenance therapy. But in your practice, some of those patients is only chemotherapy 6 cycle, that's follow-up?
So
with wild type patients.
All right, so HRB patients, if they actually went and they achieved CR and they weren't high risk to begin with, I actually offer treatment-free maintenance. However, majority are actually high risk to begin with, and especially for advanced stage, and they are always offered bevacizumab as a maintenance if they were HRB.
Yeah, I think we use more and more for those Paula protocol combination therapy for quite number of the patients. Even the quality of life that's good is I know only that's the every 3 months every 3 weeks to come for the. Otherwise, there is no major toxicity. We didn't say that much of the proteinuria hypertension, but again, we have to look for that, especially the hypertension in those patients. Especially those patients is only maintained for 15 cycles. It's not like the disease. How is the toxicity in your patients?
Honestly, I know, but if you actually experience one horrible toxicity, it will hunt you down. But luckily, majority of my patients are doing well. And if at any time they experience any kind of grade 3 or like nephrotic range proteinuria, you can always stop bevacizumab and continue with the PARP inhibition.
Yeah.
I think one thing that I may ask is majority of Solo 1 or Paula 1, they address 2 years. However, they allow you for an additional year. So I personally continue for 3 years for those with residual after 2 years. But I would love to hear from you, Dr. Walid, or...
I'm stick to the trial. Usually 2 years. For only extreme those patients, I maintain 3 years. Most of those patients, I do 2 years. I'll stick to that. There is questions regarding MDS and the myelodysplastic syndrome. It's very rare to start just to see. I didn't have only one patient during the 5 years of those patients. One of those, she has asked the questions regarding acute myeloid leukemia and MS with olaparib.
So what will you do if it happens? It's very rare. It's almost 1% in the majority of these studies, but if it happens, you'll have to stop olaparib, obviously. And treatment would be guided by hematology, not oncologist.
Yeah, and by the way, I think that very, very low risk of those patients with MDS, but once there is refractory pancytopenia, I think should be do bone marrow and refer to the hematology. Any questions? Thank you, Dr. Mohammed.
Thank you.
Assalamu alaikum wa rahmatullahi wa barakatuh. I'm Dr. Bassam Basulaiman, Chairman of Medical Oncology at King Fahd Medical City. I will have honor to moderate the next session, which is a satellite of for GSK. So in the next 30 minutes, after this long session about the ovarian cancer, and we discuss how is the update and evolving in the management of ovarian cancer in the last years. We'll have a talk about how's the treatment paradigm in advanced ovarian cancer, and specifically we'll concentrate on niraparib data. So I would like to welcome the speaker here, Dr. Hashim Al-Hashim. He is the medical oncologist and head of medical oncology department at King Saud Medical City, King Saud University Medical City. So welcome, Dr. Hashim.
Thank you very much, Dr. Bassam, and thank you and congratulations for Dr. Nashmiya for successful meeting. So I will talk about redefining the treatment paradigm in advanced ovarian cancer. Some of the slide is just mentioned earlier, and Dr. Thomas and Dr. Muhammad made my life easy. So I will try to skip the repeated slide and concentrate on the differences between the first-line treatments in advanced ovarian cancer. So this is my disclosure. And as introductions, we know that ovarian cancer is the fifth leading cause of cancer death in women, despite only affecting 1.1% all new cancer cases, with a 5-year survival is only 50% of all populations. And it is a disease characterized by high rate of recurrence, and up to 90% patient with stage 3 they will have recurrence, and up to 95% patient with stage 4 disease will have recurrence after curative treatment in the upfront setting. And as mentioned, that it is associated with multiple relapses. So the most important things, since if it is relapse, so the control of the relapse, and you can see the progression-free survival becomes shorter and shorter with each relapse. So first-line treatment is the optimal setting to achieve potential cure for patients with locally advanced or advanced ovarian cancer. Was mentioned earlier many times today that bevacizumab role in advanced ovarian cancer, and we know from GOG 218 and ICON 7 that it has only modest benefit in progression-free survival, but there is no benefit in overall survival in the overall population, except in patients with high risk, as shown in ICON 7. Alteration in HR gene in high-grade serous carcinoma is common, with almost 50% of patients with ovarian cancer are HRD positive. Half of them are BRCA related, either somatic or germline mutations, and other half are due to other measures, genomic instability. And the gold standards, or the most available one, is uses Myriad My choice testing, and they define HR positive by calculating of LOH, TIL, and LST. And if the cutoff is more than 42%, 42, the threshold is 42, they consider it as HRD positive. We know that we have 4 major trials was tested in first-line setting: SOLO-1, PAOLA-1. Both of them, they tested olaparib with or without Avastin, and you have PRIMA for niraparib and Athena mono for caparib. So the SOLO-1 trial was exclusively for patients with germline or somatic mutations, as mentioned earlier, with primary endpoint progression-free survival, and including both low risk and high risk population. And it showed it achieved its primary endpoint for progression-free survival with hazard ratio 0.33. So it's very significant improvement of progression-free survival. And the benefit was seen in both higher risk and lower risk subgroup. It's very important to keep in mind that 44% of SULO-1 trial are considered lower risk group. They are excluded from a measure of other trials. Also, maintenance olaparib provided clinically meaningful overall survival, albeit it's not statistically significant due to alpha assignments. PAOLA-1 is mentioned in details by Dr. Muhammad, so not to go in details here, but they include all stage 3 and stage 4 disease, regardless of BRCA and HRD mutations, and they give it for 2 years maintenance olaparib with bevacizumab. I will just concentrate here that half of the patients are HRD positive populations and other are HRD negative. Again, it's achieved its primary endpoint for progression-free survival with improvement of progression-free survival from 16 to 22 months with very significant hazard ratio 0.59. The benefit was seen in almost all the specified subgroup, but I will concentrate here and patients with, if you can see here, patients with partial response, they have lesser response comparing to those patients with complete response or no evidence of disease. And this may explain the result of other trial since the partial response is different in terms of percentage in terms of all of these 4 clinical trials. Progression-free survival was highest in patients with HRD positive BRCA mutated, followed by HRD positive BRCA wild type, and we don't see any benefit in patients with HRD negative populations. It is the same for overall survival. There is no benefits in intention to treat populations, but if you look by subgroups, there is the highest benefit was seen in patients with BRCA mutated, followed by HRD positive, and again, there is no benefit in patients with HRD negative population. Athena mono, it was not approved yet, but it is a 4-arm trials. Athena mono arm is comparing maintenance rucaparib versus placebo, and it showed benefit in intention to treat population and HRD positive populations, and the benefit was seen even in HRD negative populations. But here they define the HRD by LOH only, not by the combinations of the 3 parameter as per myriad choice trial. PRIMA trial, which evaluated niraparib maintenance treatment in patients with newly diagnosed high-risk advanced ovarian cancer. So here it is exclusively for patients with high-risk disease, patient randomized either to placebo or maintenance niraparib 300 or 200 milligram dose for 3 years. And the key exclusion criteria PRIMA trial that they excluded patients with stage 3 disease who have complete cytoreductive surgery after primary cytoreductive surgery. So, i.e., those with no visible residual disease are excluded, but they are included in other trials. With the primary endpoint here, progression-free survival, and bevacizumab maintenance therapy was not permitted in either arms. The PRIMA, they used individualized starting dose. So after maybe 2/3 of the patients were included in the trial, then the protocol was amended and they adopt the individualized started dose as 200 milligram if the patient weight is less than 77 or than 50. Otherwise, they will use the 300 milligram dose. The baseline characteristics show the high-risk population. So 35% of patients had stage 4 disease. 2/3 of patients received neoadjuvant chemotherapy. 1/3 of the patient has partial response to first-line platinum chemotherapy. Half of the patient are HRD positive, and 1/3 of the patient are BRCA mutated, and 1/3 of the patient are HR proficient tumor. So it is exclusively including patients with high-risk populations. And PRIMA trials meets primary endpoint for survival in both HRD positive and overall populations, with hazard ratio 0.43 and 0.62 subsequently. In the updated analysis, still in the primary analysis, we see the benefit of progression-free survival was seen across biomarker subgroups, including all overall populations, HRD and HR proficient populations, with highest benefit was seen in patients with HRD BRCA mutated population. In the updated progression-free survival that was presented in 2024, still we see that niraparib PFS benefit sustained with additional follow-up in overall HRD and HR proficient population with significant p-value in all the three subgroups. So among patients with HRD positive populations, at 5 years, we can see the difference 35% for patient who has maintenance niraparib versus only 16% on placebo arm. The time for subsequent therapy was prolonged by 5 months in overall populations, but no different BFS2 was observed in both arms. Final overall survival, as mentioned earlier, that showed there is no difference in overall survival between niraparib and placebo arm in the overall HRD and HR proficient populations. And this can be explained by many theories that we'll discuss in details. So this forest plot shows that overall survival are consistent with those with the intention to treat populations. So what is the factor impacting the overall survival? So there is 3 main factors impacting overall survival benefit in PRIMA trial. The first one is to include high-risk patient populations. And second one, extended post-progression survival and high rate post-progression PARP inhibitor therapy. So let's go one by one. So for high-risk patient populations in PRIMA trial, this paragraph or this picture showed you the difference in patient population between all of the phase 3 bivital clinical trials. And we can see here that PRIMA trial, including the high-risk population in terms of including higher stage 4 disease, higher patient with visible residual disease, 2/3 patient received neoadjuvant chemotherapy. It is the highest of all the trial has partial response to comparing to the others, and 70% patient has BRCA wild type populations comparing to, for example, SOLO1, which is exclusively for BRCA mutant populations. And we know that from this retrospective analysis from Flatiron trial that there is the probability of survival decrease with the increasing number of high risk factor. So patients with 0 risk factor that have highest overall survival compared to those has 4 risk factor or higher. The second point is extended progression, post-progression survival. In a PRIMA trial, we see that there is very long extended progression-free survival. And we know that demonstrating overall survival benefit is challenging with long post-progression survival, and the probability of showing statistical significant differences will decline rapidly with prolonged post-progression survival. But progression-free survival will not be affected by this PBS, unlike overall survival. And the PRIMA trial, the post-progression survival exceed 32 months, and post-progression survival defined from the time of progression till the time of death. And with longer post-progression time, patient heterogeneity and post-progression treatment can dilute the difference in overall survival between treatments arm. Third point, there is high rate post-progression PARP inhibitors. And we can see here that subsequent anti-cancer treatment across study arms in PRIMA trial, and we showed that among patients who experience disease progression, that there is a difference in subsequent therapy across treatment arm, mainly in the PARP inhibitor subsequent therapy. And we can see here that the subsequent PARP inhibitor use was most predominant in patients with HRD populations, achieving more than almost 60% of the populations in patients with BRCA mutant populations. And the most of the subsequent PARP inhibitor was used as second-line therapy. they did adjusted statistical analysis, and this adjusted statistical analysis using 3 different methods: RBSFT, 2-stage AFT, or IBCW. And we can see with the statistical analysis, it showed that it suggests that the subsequent PARP inhibitor may impact the overall survival Kaplan-Meier curve. And it's very important to note that the PRIMA trial enrolled the highly platinum responsive populations based on radiological, as it's only 30% has a partial response. Biochemical, they only allowed patients who had CA125 in normal range or declined more than 90% during the frontline therapy and stable for more than 7 days. And half of the patients are HR deficient populations. In terms of safety, the most common grade 3 adverse effect with niraparib is thrombocytopenia, anemia, and neutropenia. And we can see that was improved with individualized starting doses compared with fixed starting doses. MSD events were reported in 2.3 patients who received niraparib and 1.6 patients who received the placebo. It's important to notice that 3 patients out of these 11 patients, they developed while receiving subsequent line of therapy, including subsequent PARP inhibitor therapy. Quality of life was similar between both groups, including patients who has prolonged survival. The question, and this slide was mentioned earlier, do we need bevacizumab in patients with BRCA mutated populations? In GOG trial, the bevacizumab highest benefit was noticed in patients with BRCA wild type and to lesser benefit in BRCA mutated populations. And BAURA trial, both are containing bevacizumab. So do we need to add bevacizumab in these patient populations? So there is 2 ongoing clinical trials. You have Nirvana trial, which is a phase 2 clinical trial, and we have INGOT trial, phase 3 clinical trial. And both of the trial, they randomized patient to maintenance bevacizumab alone or maintenance bevacizumab with niraparib. So what is the role of maintenance immunotherapy? So it was mentioned also earlier today that immunotherapy is a failure in patients with ovarian cancer. So avelumab was the first drug tested and it's just not active in ovarian cancer, so it's negative. The second one, we have atezolizumab. Again, atezolizumab is negative in the first and subsequent line of therapy also. Athena combo also, which is comparing rucaparib nivolumab versus rucaparib maintenance only. Again, it is not only negative, actually it is a detrimental effect, as you can see here. The patient who received maintenance nivolumab has worse outcome comparing to who's not receiving it. DUO trial, which is exclusively for patients with non-BRCA mutated, which is 3-arm trial with the primary endpoint comparing the triplet bevacizumab, durvalumab plus olaparib comparing to control arm, which is bevacizumab maintenance therapy here. And it showed that in the second arm, which is including CV plus bevacizumab, there is no difference in the benefit. But in the triplet arm, yes, there is a benefit. But you have to keep in mind that there is no olaparib containing control arm. So it's not possible to quantify the contribution of immunotherapy here. And it shows no improvement in overall survival, both in non-BRCA mutated HRD or non-HRD. KeyLink 001, which we know that is considered positive trial, it showed improvement in progression-free survival with olaparib plus pembrolizumab with oral bevacizumab, a 3-arm trial, which is maintenance pembrolizumab with olaparib, or maintenance pembrolizumab alone, or maintenance placebo. And it showed benefit in patients with CPS more than 10% or intention populations for maintenance combinations pembrolizumab plus olaparib. But there is no overall survival benefit that you can see here. And again, there is no olaparib containing alone arm, so it's not possible to quantify the contribution of immunotherapy here. And pembrolizumab alone arm, it's failed to show benefit. Last trial, which is first trial, which demonstrate improved improved progression-free survival with niraparib plus with absolute benefit 1.4 months in intensive population. There's no benefit in overall survival comparing to maintenance paclitaxel plus dostarlimab. So the triplet showed improvement, but with toxicity. So all of these immunotherapy trials have toxicity compared to no immunotherapy. So in conclusion, in the current era, all patients with newly diagnosed advanced ovarian cancer should undergo BRCA or HRD testing early in the first-line setting. BRCA mutation status is the strongest predictor of benefit and prognosis. PARP inhibitor provides statistically and clinically meaningful PFS benefit, more pronounced in patients with BRCA and HRD host populations for niraparib, but the benefit was seen across all subgroups in patients with niraparib. And there is currently no established rule for maintenance immunotherapy in the first-line setting, given the marginal clinical benefit and increased toxicity profile. And this is the NCCN guideline as shown earlier by Dr. Muhammad. And thank you very much.
Thank you, Dr. Hashim, for your presentation. And now we'll open the floor for question. I will start with Dr. Prof. Ahmed.
Interesting talk. Thank you very much. Now, after 6 years from PRIMA trial, we were in ISMO 2019. It was really great event when they talk about PRIMA with the role in proficient cases, and you nicely presented the challenges in the design of the trial that may be the cause of the negativity of the overall survival. So do you think that still the role of niraparib in the proficient cases after this PRIME and PRIMA is still there? And in case of patient facing some difficulties in the, keeping the dose of 300, 200, so do you think that de-escalating the dose to 100 also may be of benefit, because we are facing this hematological toxicity sometimes? Thank you.
Yes, thank you very much, Dr. Ahmed, for this very important questions. So just to start with, all of the PARP inhibitor clinical trial, they failed to show statistically significant improvement for overall survival. Yes, there is clinically benefit for overall survival, especially with SOLO-1 trial, but all of them are statistically negative trial. And as mentioned earlier also by Dr. Thomas, it is not a detrimental effect. Overall survival benefit of maintenance niraparib, but was affected by multiple factors was mentioned in the clinic, and as I mentioned in my presentations. In term, as you mentioned here, it has the longest one has almost the median overall survival 6.2, and now is more than 6.2. But this is the presentation last year we have. In terms of toxicity and dose adjustment, they realize that 300 milligrams is not fit for all patients because of toxicity. And we can see that after they do the dose adjustment, the toxicity showed favorable outcome compared to the fixed starting dose of 300. So what I'm doing in the practice actually for patients who I think they are fragile patients, is out of the standard, I'm starting sometimes with 100 milligrams. And I escalated to 200. Patient weight is less than 77. But for patients who are fit, I go with the trial. So either based on the weight and height. But I found all of the patients who started in 300, the dose was reduced to 200, and some of them reduced even to 100. So do we know if it's effective? So in general, as we know that all of the dose adjustment was done for toxicity was not affecting survival, but I think we have to have specific data for PRIMA that dose adjustment is not affecting survival. So I don't know if it was presented or presented by JSK yet.
There is a question here from the online audience. The PRIMA showed the benefit with niraparib, even in HRD negative patient. How do you balance this benefit against the toxicity and cost when choosing maintenance therapy in these patients?
Yeah, it's a very important question. Again, profile is very important to take here. So we know that the benefits in patients with HR proficient population is lesser compared to patients with HRD with populations, and only USFDA that would draw out narrow the indications, but still indicated for all comers in Europe and Saudi Arabia by Saudi FDA. So you have to choose your patient. Patient is fit. I think it is unfair to keep her without maintenance niraparib after shared decision making. Patient to understand the risk and benefit of the therapy, and with close follow-up. Especially in patients with HR proficient populations, given if they had difficulties, so I will be more relaxed or more comfortable in stopping the medications or very fast to do dose reduction compared to those with HRD with the population.
Thank you, Dr. Hashim, for your presentation. I also to thank the audience for their question, and I would like to thank JSK for this. I would like to conclude the JSK Satellite Symposium here, and we'll have a break for 10 minutes now. Okay. So sharp 10 minutes. We have.
Prof. Isabel, good morning.
Morning.
How are you? I hope you're having a good time.
Yes, very nice. Thank you so much.
Welcome. Would you like to test your presentation? We'll be back in a few seconds. We are now on a quick break.
Do you see my slide?
Move forward a couple of slides to make sure it's moving smoothly. Yes, yes, yes.
When we will start, just to know.
Maximum 2 minutes.
Okay, perfect.
Assalamu alaikum. Now we'll start our second session, ovarian cancer. It's my pleasure to introduce our moderator, Dr. Bassam Suleiman. He's a consultant medical oncologist from King Fahd Medical City, Riyadh, and Dr. Amin Tijani, consultant medical oncology from Ministry of National Guard, Medina Munawwara.
Thanks, Dr. Nashmiya, for introduction. We'll start now our next session, which will be our about continuing the ovarian cancer management, and we'll move to moving toward precision medicine and ovarian cancer management here. I would like to welcoming our international speaker, Prof. Isabel Ray Cockort. She's a president of the European Network for Gynecological Oncology Trial Group, ENGOT, and the director of the Network of Reference Center for Rare Gynecological Cancer, and professor of medicine and medical oncology, University Claude Bernard Lyon 1, and the head of EMS research group at the University Claude Bernard Lyon, France. So, Prof, are you with us, Prof. Isabel?
Yes, I'm there.
So, yeah, I hope next time we'll see you here in Riyadh. Welcoming you here, and we have now our weather is very good nowadays, and we hope next time we'll see you here in Riyadh, inshallah.
It will be wonderful. First of all, I would like to thank you for your invitation. Also, it's not in person but virtual, and I would like to wish to all of you a fantastic new year 2026 with good health and a lot of projects for you and your team. You asked me to speak about ovarian cancer, but focusing on the precision medicine, which is finally the goal we would like to see for all our patients. And to be honest, since the beginning, ovarian cancer was not the big big famous story considering using targeted treatments. This is my disclosure. And before to start, more generally, one of the reasons why we were not able to develop so many precision medicine in ovarian cancer is that finally, ovarian cancer are not only one single disease, but a complex and a poor prognostic population of several different diseases. And also, if we are focusing on high-grade serous ovarian cancer, which is the most frequent, we have to recognize that 60% of these patients were diagnosed with an advanced stage. And whatever we are doing in the first line, 70% of these patients will relapse and the majority will die within the 5 next year. Also, we are doing everything we can. And if we concentrate our focus on the high-grade serous ovarian cancer, we have also to remember that within this group of patients, we have finally two different diseases, at least now split with the homologous recombination deficiency test. We can be able to separate the patient with a huge sensitivity to platinum and PARP and the HRP population, where I will come back on this topic later. So, focusing on high-grade serous ovarian cancer, the precision medicine start to be included in our guidelines when we were able to demonstrate the activity of PARP inhibitor in this particular disease, considering BRCA mutation, but also HRD test. And effectively, in our guidelines, it is mentioned that we need to promote BRCA status and HRD test for all our patients high-grade ovarian cancer, except mucinous ovarian cancer. However, if we are now very clear about what is an HRD test and what is the add value in terms of prognostic, we have seen that a patient with an HRD test negative have a poor prognostic disease compared to an HRD test positive. We also seen that the HRD test reveal particularly the huge sensitivity to PARP inhibitor, looking to all the different trials we have seen in the first line setting. However, we have to be careful about what is the HRD test. Is not a panel of including homologous recombination repair gene. Why? For two reasons. First, if you look at the homologous recombination gene, BRCA and all the other, finally, the number of patients seems small. 13% in first line, in relapse, 70%, 7% in the first line setting. And more importantly, when we look at the activity of olaparib in this group of patients with an HRR test positive beyond BRCA, I don't speak about the BRCA, we don't see a benefit to use PARP except for those where the HRD test is positive. That means that when we are speaking about an HRD test, we have to be clear that we need to use an HRD test validated from a technical but also from a clinical point of view. And this is really important. Coming back to the role of PARP inhibitor, we immediately see, looking to the table reporting all the different phase 3, that the gradient of activity is really depending of the BRCA mutation or the HRD test. And for the HRD negative population, the magnitude of the benefit is really small. And now coming back in the detail about the precision medicine in front of the management of the patient, finally, we are speaking about that only for the maintenance setting. And it is in the maintenance after surgery that we will decide what could be the best option for our patient depending on the BRCA testing and the HRD testing. And if we go back to BRCA mutation, for example, we have today the opportunity to compare the use of PARP inhibitor in this group of patients alone or in combination. Why? Because the magnitude of the benefit in solo one in the BRCA mutated population is so evident in terms of PFS and overall survival that there is no doubt that this population should have to receive at least 2 years of PARP inhibitor in the first line setting. The role of BEV in this population, also in the Paola 1, we report similar benefit compared to solo 1, and we have in the control arm a maintenance active control arm with the BEV. We can't say really what is the magnitude of the benefit of BEV in this group of patients. However, I just want to insist on the control arm. If you look at the solo 1 trial, the median PFS with a placebo is close to 1 year. If we had BEV in this group of BRCA mutated patients, the control arm is close to 22 months, which is not so bad. Now, how we can be able to decide? The overall survival in the 2 trials are positive in favor to use PARP alone or in combination with BEV, but we don't see again what could be the best option for our patient in this group. Do we have to go more in the granularity of the BRCA mutation? This is a question that we try to address looking to the solo 1 and the Paola 1 data. And what it is interesting to see is that in the solo 1, for example, the other ratio considering BRCA1 versus BRCA2 with olaparib alone is quite similar. It's quite different. 0.4 for BRCA1, 0.2 for BRCA2. Thinking that for BRCA2 mutated patient, olaparib works very well. In Paola 1, when we look at the use of BEV in combination with olaparib, you can see that the other ratio in the BRCA1 and in the BRCA2 is quite similar. So perhaps when you have a patient with a BRCA1 mutation, it could be a factor to consider the combination compared to the monotherapy. There is also this work developed by Intidar Labidi, which is very nice to reveal that also olaparib is working in all the BRCA mutated population. We see that the magnitude of the benefit of PARP inhibitor can be really different if we are looking to the localization of the mutation on the BRCA1 or BRCA2 gene, looking to the ring in the ring domain versus in the DNA binding domain, where it seems that PARP inhibitors are particularly efficient. And I have to say that in my multidisciplinary tumor board, when we have to discuss to add BEV or not in this group of patients, sometimes we are looking to the type of the mutation, also the localization of the mutation to consider if we are using the combination or the monotherapy. Now, for the HRD positive BRCA wild type, we also have the opportunity to use PARP inhibitor alone or in combination with BEV for 2 years or 3 years. And so effectively, we have the Paula-1, Prima, and Athena, who report activity of PARP inhibitor in this group of patients. The other ratio is 0.43 for the combination compared to 0.5 or close to 0.6 considering the monotherapy. To decide, we don't know exactly. The long follow-up we have with Paula-1 in the HRD positive population is to say that we have close to 50% of these patients who did not progress during after 5 years, which is a very nice result compared to what we see before. And when we try to explore the difference looking to the same population, that means the Paula-1 mimic the Prima population versus the use of niraparib, it seems that we see a benefit to add bevacizumab in combination with the PARP compared to the PARP alone in this group of patients with a poor prognostic disease. There is also the results with the overall survival benefit we have seen with the combination in this group of patients. Also, we see that 50% of the patients in the control arm receive PARP inhibitor in the relapse setting. The results were quite very good. And we also see an advantage in the BRCA mutated, but also in the HRD non-BRCA, supporting the use of the combination. And unfortunately, we don't see overall survival benefit in the Prima final overall survival analysis, also in the BRCA mutated population, where we were very surprised about these results. So for the HRD negative population, you have to remember that this group of patients continue to be a very heterogeneous group of patients. And when we look at all the different results in this group of patients, I have to say that PARP inhibitor brings some benefit in the Prima and Athena trial. There is no benefit in the Paula-1 population when the control arm is using BEV, and the magnitude of the benefit of PARP inhibitor in this group of patients is not so high. However, you have to remember that this group of patients include different populations. That means that we have put in this group of patients cyclin E1 amplified population, DMMR population, NER mutation, RB1, and so on. And probably in the future, we will be able to decipher also this population to consider new option. And one of the new option I would like to highlight for you is the WEE1 inhibitor. Effectively, these drugs are particularly interesting in the group of patients with cyclin E1 amplification or overexpression. And recently we have seen some very nice results with different drugs, and we know that these drugs are coming soon in the clinical trial in the HRP population. The other way to try to find new options with some precision medicine is to try to explore EDC. We have seen a lot of activity in the resistant population with ovarian cancer, so perhaps HRP, which are less sensitive to platinum, could be also a good option. And we can imagine in the future to have several EDC targeting different membrane receptors, who could be, again, precision medicine in this population, able to improve the PFS and perhaps the overall survival of this poor population. Now, in the future, considering the progressive disease in the platinum sensitive, there is probably different options to explore. The first one is the patient who progress during PARP. We have seen that the patient who progress during PARP are less sensitive to platinum than the other. It was reported with the Paula-1 data, and now we have seen that. I think it will be very interesting to explore new options in this population, and EDC targeting several membrane receptors could be interesting. I just want to remember you the Piccolo data in the platinum sensitive relapse with the mirvetuximab report very nice results in this population. The alternative for the patient who did not progress during PARP is to propose to re-challenge this patient with a PARP inhibitor if they are particularly sensitive to platinum-based chemotherapy again. This is the trial that we will move quickly in the future to re-challenge precision medicine using a new PARP in this group of patients. Now moving to the platinum-resistant ovarian cancer, which is the poor prognostic disease in ovarian cancer. Unfortunately, until recently, our standard of care includes single agent chemotherapy, including PLD, weekly paclitaxel, topotecan, plus or less BEV. Bev was not used before. However, the activity of this chemotherapy are very low in terms of response rate, but also in terms of PFS and overall survival. If we try to explore immunotherapy in ovarian cancer in several large phase 3 in the first line, but also in the relapse setting, unfortunately, we will not receive until recently positive results in ovarian cancer. And we finally consider that the PD-L1 expression were systematically lower than 40 or 50% can explain that this tumor could be considered to be immunologically cold and need to explore different options, more precision medicine, more selective population in the future. And effectively, it was what the Keynote B96 promote, exploring the combination of weekly paclitaxel, BEV, and pembrolizumab in this population of patients, particularly in the group with a PD-L1 positive expression. This trial report positive results this year at the ESMO Congress, considering PFS in the CPS and the ITT population. Also, the median advantage is 1 or 2 months. They also reveal overall survival in the CPS positive population with another ratio of 0.76 and a median benefit for overall survival of 4 months. There is also some side adverse event as we anticipate, particularly for immune-related adverse event. There is 11% of patients with serious immune-related adverse event. And as you can see on the table, close to 36% of the patients stop the treatment, one of them, during the continuation of the trial in line with the treatment-related adverse event. And when we look at the immune side effect, finally, colitis, with probably a little bit more important in this group compared to the placebo arm, have to be carefully followed up. How we can explain the positive results after so many clinical negative trials? I think we need to remember that it is a very large international trial with a strong study design able to make the demonstration, considering a very well selected patient population in terms of few number of lines of treatment before and rich in the positive biomarker population, more than 70%. The use of weekly paclitaxel enhanced the activity of pembrolizumab, and the addition of bevacizumab for more than 70% of these patients revealed the good performance status of these patients, but also will be able to enhance the activity of weekly paclitaxel, as we have seen with Aurelia and also pembrolizumab. And this is something that we already have seen in the AGO-OVA 2.29 in the subgroup of patients who receive weekly paclitaxel in combination with BEV and atezolizumab. We see an advantage in terms of PFS and overall survival in this subgroup of patients compared to the patient who received only PLD. However, in the meantime, we see new agents coming in the same setting. The relacorilant plus nab-paclitaxel, positive results. We are waiting for the regulatory access, but also the mirvetuximab soravtansine, who report positive overall survival in the group of patients with an FR-alpha high expression, which is precision medicine in this group. And we know also that there is several other EDC coming soon. I just want to re-insist on the mirvetuximab soravtansine, who report for the first time positive results using an EDC targeting the FR-alpha PS2 intensity population, which is representing between 35 to 40% of our patients with a platinum-resistant ovarian cancer. The median PFS and the median overall survival bring with this monotherapy compared to chemotherapy are clinically and statistically significant. And the recent update by Toon van Grop last year confirmed that we have seen in the primary analysis, considering PFS benefit, but also PFS2, overall survival, and objective response rate compared to chemotherapy. And effectively, you can see on the slide that we continue to see the curve completely separate since the beginning, and the other ratio is 0.68 using this monotherapy. However, how we can make any comment on these different large phase 3, Mirasol, Rosella, and B96, also you can see immediately with the table that the population are completely different, considering the line of treatment, the platinum-free interval, the use of BEV before, very few in the B96, the use of PARP before, very few in the B96, and the control arm adding systematically BEV, yes or not. It's very complex. And we have to say that there is new drug also coming soon. I have report this year at the ESMO meeting, the Rejoice Ovarian 01 part 1 study exploring different dose of RDXD. And what we have seen is that in the Rejoice Ovarian 01, we see activity with these RDXD EDC targeting CDH6, similar activity, whatever is the dose between 4.8, 5.6, and 6.4, with a little bit more response rate using 5.6. And because of the side effect and the activity, we consider now that for RDXD, 5.6 milligram per kg is the optimal dose in ovarian cancer. And what it is interesting with this drug is that we seem to see activity in the different tumor across CDH6 expression level, which will be interesting to confirm in the phase 3. We also see some activity also targeting FR alpha membrane receptor with a new EDC soft hem, as we can summarize. And what it is interesting is with this drug is that we see activity also for the low and intermediate FR alpha expression population, and also after mirvetuximab, which could be interesting in the future to consider if this drug is coming in routine. The biomarker challenge will be the future of ovarian cancer, and I'm very happy on that. Why? Because that means that we increase the chance to see precision medicine. The question will be about the PD-L1 expression. Do we have to consider is the best biomarker to reveal immunotherapy? I'm not sure. What about the patient who have an overlap of the FR alpha high and PD-L1 positive expression? In ovarian cancer, we don't know. And for the double positive population, FR alpha high and PD-L1, what could be the relevance to use mirvetuximab and pembrolizumab? This is something that we have to consider perhaps in the future, looking to what we see in the phase 2, where in this group of patients, the duration of response of mirvetuximab plus pembrolizumab is very long compared to the other group of patients. So the conclusion in the platinum-resistant ovarian cancer, looking to high-grade serous ovarian cancer, is that weekly paclitaxel plus BEV continue to be our best standard of care, adding pembrolizumab for the CPS positive population. Together, these advances of mirvetuximab and relacorilant help us to have more options than before, but we need to remember that we need to continue to explore new options in this group of patients where 50% of them continue to progress 6 months after the initiation of the treatment, and the median overall survival remain low. Now moving to the rare epithelial ovarian cancer, which is 50% of our patients, and these patients continue to receive the same treatment as our high-grade serous ovarian cancer. But when you look at the activity of our standard of care, in general chemotherapy, you see that the activity is very low compared to high-grade serous. In general, the response rate is always below 20%. And when you look at the biology of this tumor, you immediately understand that using chemotherapy, particularly platinum, is not the best way. Why? Because there is no BRCA mutation, there is no HRD positive test in this group of patients. In the other hand, there is a lot of HER2 amplification, there is more TMB positive, DMMR, but also KRAS mutation, PI3K. So that means that we need to consider different options. And it is what the Bouquet trial tried to explore for this patient. After platinum-based chemotherapy, the patient received a screening using the FMI platform, and looking to what we see in terms of molecular alteration, the patient can be included in different cohorts of targeted treatment alone or in combination. And if we look at the most recent data, we see that cobimetinib alone was particularly efficient in the low-grade serous ovarian cancer with BRAF and KRAS mutation. The response rate, the duration of response are really interesting. But you have to remember that we also see similar results using avetumotinib, a MEK inhibitor, plus defactinib, a FAK inhibitor, in this population of low-grade serous ovarian cancer, where we see that the response rate in the KRAS mutated, but also in the KRAS wild type is not so bad, and the median time to response is short, and the duration of response is very long in this phase 2. And we are right now finalizing the phase 3, where I hope we will see the results soon, and to be considered that if the phase 3 will be positive, the combination will become our standard of care. However, this remains several questions, looking to all the data we have considering MEK inhibitor in this group of patients. Do we have to consider MEK inhibitor alone or in combination? Because we see that there is some difference. And when we look at the KRAS mutation versus the MAP kinase wild type population, you see that the response rate, the median PFS, the duration of response are not exactly the same. And the question will be for the wild type population if this drug have to be proposed in the future. There is also alternative for low-grade serous ovarian cancer. You know that the majority of these patients express hormone receptor, and we try to explore the combination of giredestrant plus abemaciclib in this group of patients. And as you can see again, we see nice results, not so much in terms of confirmed response rate, but look at the disease control rate, 50%, median PFS, close to 1 year, 10 months, which is quite nice compared to what we see with chemotherapy in this group of patients. Again, we also explore the combination of inavolisib, which is an inhibitor of PI3K alteration, plus palbociclib, CDK4/6 inhibitor. And again, particularly in the clear cell population, we see very nice results with this combination, 25% of response rate, disease control rate 63%, median PFS 8 months, which is much more what we never seen before using chemotherapy. And effectively, in ovarian clear cell carcinoma, we have also seen that immunotherapy could be something very interesting, alone or in combination with anti-angiogenic as bevacizumab, looking to this phase 2 already report in 2022. And we are now waiting for the DOVE trial, exploring the dostarlimab plus bev versus the dostarlimab versus standard of care, where I think the data will be positive in the near future. There is also, for patients with no biomarker, no molecular alteration, this combination of atezolizumab plus bev plus metronomic cyclophosphamide, who in the Bouquet trial report nice results in terms of response rate, 32%, but also disease control rate, median PFS, in this group of patients, including clear cell, low-grade carcinosarcoma, which is always better than what we see with chemotherapy. I would like to mention also HER2 amplification, where we have seen with carcinosarcoma very nice results using TDXD, and it is the case probably for all HER2 overexpressed population, and I hope that we will be able to use this kind of drug in the future, considering ovarian cancer. So if we have to conclude about precision medicine in ovarian cancer, the precision medicine starts with the maintenance treatment in the first line, particularly looking to the BRCA and HRD population, where PARP inhibitor brings some benefit, PFS benefit for all the PARP, OS benefit looking to SOLO-1 and PAOLA-1. The HRP group continue to be a poor prognostic disease, very heterogeneous, and we need to develop new alternative therapy in this group of patients, including a WEE1 inhibitor, CDK2 inhibitor. In the relapse setting, if I have to specify some biomarker to explore in the future, I will mention HER2, FOLR1 expression with mirvetuximab, but also PD-L1, KRAS and BRAF for the low-grade serous ovarian cancer, expression particularly for low-grade serous ovarian cancer, and perhaps in the future CDH6, Claudin-6, Cyclin E overexpression have to be explored. So the future priority for us will include biomarker-driven patient selection. That means that we will be able to optimize our sequencing of the drug, but also we need to be sure that we will have enough energy and data to ensure an equitable access to testing, but also for new innovation for all our patients. Thank you so much for your attention.
Thank you so much, Professor Isabel, for this excellent review for precision medicine in ovarian cancer. So stay with us. We have another presentation before the discussion. So our next speaker will be Dr. Mohammed Saifan. He's head section and consultant medical oncology at Security Forces Hospital, and also he's assistant professor at Princess Noura Abdurrahman University. So he will speak about translating data into real practice. It is a case presentation.
Assalamu alaikum. Good afternoon again. Thank you, Dr. Amin, for the kind introduction. So here we are going to bring some case scenarios, hypothetical, addressing available evidence so far. Usually it's more interesting. I thought it would be more interesting in endometrial, but I think you guys would see. Let's see what happens. Anyhow, case number one is a 53-year-old female who's not known to have any medical illness, diagnosed with stage 4A high-grade serous ovarian cancer, germline BRCA wild type, somatic BRCA wild type, a genomic instability score of 85. How can I see? Okay, so HRD basically BRCA wild type, discussed in the tumor plan and the tumor board, and the plan was to start with chemo with interval debulking. So which regimen would you choose for this patient? Paula 1 regimen, and to hold 1 cycle of bevacizumab pre and post surgery, or would you go with the platinum-based chemotherapy followed by niraparib or rucaparib maintenance, or just chemo and bevacizumab maintenance for such a patient? So I'll ask, so basically the voting is for the virtual attendees. We'll give them like 2 seconds to answer. So till we have, so we can see that virtual attendees, almost 50% voted for Paula 1. Chemo with PARP maintenance and another like 37%. And there are 17% who voted for bevacizumab maintenance. So before moving on, I would like to hear from the panelists, Dr. Amin, Dr. Bassam, what would you choose for such a patient? There is excellent performance status, no contraindication for any of the drugs.
It is HRD?
HRD, BRCA wild type.
BRCA wild type. Negative. Positive.
HRD positive, BRCA wild type. The genomic instability score is 85.
So I will go with the first option.
So you'll choose Paula 1,
yes.
omitting Bev pre and post.
Yes.
How about you, Bassam?
Yeah, and King Fahd Medical City will we'll use the first option, the Paula 1 regimen.
All right. So is there anyone in the room who would go with only PARP maintenance without bevacizumab? Anyone would go with Bev maintenance without PARP inhibition here? All right. So luckily, Bev, especially for HRD patient, we all have seen the evidence, I believe like 4 or 5 lectures so far. BARB is part of the standard for any HRD, whether it's BRCA or non-BRCA mutated patient. So I'll move to okay. So we have just seen that pre-match study, if we choose, we have excluded the third question, and PRIMA have actually achieved its primary endpoint of being PFS, and even in the HRP population. However, lack of survival advantage, which makes me a bit more in favor, similar to majority of the attendees, to choose the PAOLA-1 regimen. We do see the PFS advantage, and despite HRD positive BRCA wild type on the right, we do see the separation. Yes, it lacks statistical significance, but I would rather see something with the diverted curves rather than something on top of each other. So I'll continue with the same patient. The patient have received PAOLA-1 regimen, achieved CR, and unfortunately developed recurrence after 20 months being on olaparib. So the recurrence is already completed the BEV part, about to finish olaparib. She have developed ascites, liver lesions, CA 12.5 have increased to 523, discussed in the tumor board, deemed not candidate for secondary cytoreduction given the extent of the disease, liver metastasis ascites. So here, what would you use in this recurrent platinum sensitive setting? The platinum doublet alone, platinum doublet with BEV maintenance, platinum doublet and maybe re-entertain again BEV with olaparib, or you will give doublet and continue with the PARP maintenance re-challenge. So we'll give like 10 seconds for the virtual attendees. During so, we'll hear from the room as well. So who would actually vote for only platinum without any maintenance and platinum sensitive this scenario? Right. I see only
how much the duration from last
20 months.
From last olaparib?
20 months. Olaparib starts after chemo, so it's 20 months. 20 months.
Last olaparib, that's
finished BEV. BEV is 15 months, 20 months from starting olaparib. So it's about to finish olaparib. 4 more months and she would have been on surveillance.
This is on olaparib?
Currently, yes.
Yes. Okay.
Dr. Amin, chemo alone, type, how about platinum with BEV maintenance for this patient? Who would go for this? Type, can we raise hands? Okay, couple of the time. How about re-entertaining the PAOLA regimen again? Anyone? All right. So how about doublet and re-challenging with PARP? All right. So can we see the voting? All right. So the voting went with. All right. We see like 9% went with chemo alone, no maintenance. Like almost 1/4 went with BEV maintenance. Almost 50% went with re-challenging PAOLA despite no evidence. And we have BARB maintenance with 17%. So let me go over the evidence. What do we have so far? So this is an area that is not really with a clear standard in those who progress during or shortly after maintenance therapy. So all right. So first, what about the evidence of re-challenging with BEV after BEV? So this patient have received BEV, and now, is there any evidence to re-challenge with BEV? This is a phase 3 study that have shown a PFS advantage of re-challenging BEV after BEV. It was published in Lancet Oncology. However, if we go into the subgroup analysis and focus here, you'll see that almost everyone benefited. However, those with BRCA mutation, they did not see this benefit. You see the only line crossing the unity line was BRCA mutation. However, do we know that these population have received prior PARP or not? This wasn't really meant to be answered, especially that this trial was published in 2021. But it tells you that BEV works for everyone. Maybe BRCA, we need something else. So How about re-challenging with PARP? If for such a patient, like, yes, she progressed while on olaparib, however, it's already 20 months, which is not bad. Would there be any evidence to re-challenge this patient? So the OREO trial have answered re-challenging and platinum sensitive, however, after like 3 lines of platinum sensitive. So we don't have a clear answer of re-challenging directly after progression on PARP. But what we see here on the right, on top is BRCA mutation, on down is BRCA wild type. The evidence is similar, whether it's BRCA or non-BRCA. The median BFS goes from 2.8 to more than 5, almost doubling, whether it's BRCA or non-BRCA, which is an evidence for re-challenge with PARP inhibition. So we can't really say that it's wrong. What I found is in the real world evidence, there was like 22 patients that were in different PARP inhibitors, and upon progression, they were re-challenged with a different PARP inhibitor. And those are the patients who, this is a list of those who were BRCA mutated, progressed whether on olaparib, olaparib, rucaparib, and the second PARP is, you can see on the right side. You can see some PFS reaching 18, 13, 16 months with olaparib, where others have achieved only like 4 to 5 months, which we see from OREO. So this is sort of evidence, but again, that's the best that we have. If you look into those with specifically BRCA, because we have seen that BEV works for everyone, but maybe not BRCA. So how about BRCA patients here? So if you look on the bottom line, on the bottom part, you'll see that the response for patients with BRCA mutation, when moving from first PARP to second PARP, majority of the responses are actually stable disease, but there is like 1/4 of patients who achieve partial response. We don't see any excellent responses or CR, but you do get like a good disease stability, let's say. عدد قليل, but that's the best we have. We have no evidence. I'm here tackling all what we have in the literature. So how about re-challenging with BEV plus PARP inhibition? Honestly, there is nothing in the literature tackling this question. However, I found this study that was published in Nature, where the OPEB-01 trial here, they re-challenge, but by adding also pembrolizumab to the equation. So they give pembro, olaparib plus bevacizumab. So if you look into this graph, you'll see that in green is the patients who were, while they are receiving chemo, in gray is the maintenance therapy, and you can see the difference in duration. Again, this is a single arm phase 2, so the number of patients are very small, 30 or 35, I can't recall. But in red, you see this is the time of second line chemotherapy at progression, platinum sensitive. And on the right side, you can see the swimmer plot using this kind of re-challenge of giving BEV, olaparib, adding to this pembrolizumab. There are actually some of the responses that is still ongoing treatment. The median BFS for this combination is more than 22 months. So this is not exactly a re-challenge with BEV plus olaparib. Here we actually added immunotherapy, and the result is quite appealing to go for further future prospective studies. So the answer is we don't have an answer. There is nothing right and wrong. I think definitely BEV is there. Olaparib maybe for BRCA patients is not a wrong answer. And using the combo for those who have completed the Bowler regimen and progressed afterwards might be also a valid answer, at least in my opinion. So moving on, the patient progressed again. This time, when she progressed, she was given carbocalyx maintenance, and she was given BEV based on the evidence I showed from the phase 3 trial. While on maintenance, 4 months, developed the progression. So now it is a PROC, platinum resistant. I want to see what we are actually doing in practice in terms of testing. Is it only HER2 folate receptor alpha, BDL1 HER2 folate receptor alpha, or do you do all and plus NGS? So can we take the poll? And meanwhile, we'll see in the room. So who would do only HER2 and folate receptor alpha? Okay, so how about adding BDL1?
Oral option.
No, forget about clinical practice. What would you do if you have it available? That's my question. So coming back, if you have it available, all of these testing for your patient, would you do only HER2 and folate receptor alpha? Okay. How about adding BDL1 to the equation? Would anyone look for BDL1 in such a patient? Okay, I don't see hands. How about doing NGS as well?
Yes.
Okay. All right. So can we get the answer from the poll? All right, like almost 60% went for the combo. I'll show you, is the combo worth it or not? Right. So, all right. So to begin with, different histologies have different alterations. You'll see that high-grade serous has the highest risk of having BRCA, whereas if you go for example, low-grade serous or mucinous, you'll see more of KRAS. PI3K is more present in PI3K is more present in endometrioid. So if we focus on high-grade serous or endometrioid, it varies. However, we all know that folate receptor alpha will be needed, and I don't think anyone would argue this based on Mirasol study. I just want to highlight that folate receptor alpha expression is there, and it is highest in serous histology, ovarian, so not peritoneal carcinomatosis, advanced stage 3 and higher, and in those with higher grade. So this is a publication showing the percentage. So if you look at any kind of expression, it actually exceeds 80 or 90% in serous cancer. But remember, the mirvetuximab inclusion criteria was to have an immunohistochemistry of +2, plus expression in more than 75% of cells. So, apologies. All right, so how about HER2? HER2 status, again, is different according to histology, with highest being mucinous, followed by clear cell, followed by serous histology. And if you look into the right side, you'll see that the likelihood of expressing +3 is highest in BRCA wild type, and those with mismatch repair proficient, and BDL1 low. So this is the highest likelihood of having a HER2. However, you would actually test everyone, because if you look into the table, you'll see that even lower stages tend to have it higher, but does it have any implication on treatment? But there is always a recurrence. So having this answer would be of value eventually. So how about BDL1? BDL1 is positivity rate is higher in PROC rather than in platinum sensitive. And this can reach from 50 to 60% from different literature. And it is highest in serous and in advanced stage. I found another publication in the scientific report that claims that the positivity is actually highest in primary peritoneal metastasis rather than in the primary disease itself. So you would actually have to have, if you want a biopsy and test for BDL1, but again, do we really need BDL1? Because if you agree for the combo, BDL1 is part of that combo. And we all know that Keynote P96 did achieve its primary endpoint in both BDL1 positive as well as the intent to treat. And again, even in ESMO, they did show the overall survival for BDL1 positive, but there is a press release that all comers actually benefit from this combination. So I wouldn't really pursue or look for BDL1 in such patients. Okay, how about NGS? So this is a paper in Precision Oncology that have looked into this question. There were actually from patients who were tested, they were around 200. Of those, majority didn't have any kind of alteration. However, SCAT1 alteration was mainly, okay. SCAT1 alteration was mainly BRCA, which we already have been, we would have been doing this from the get-go. and 151 out of 168, which almost 90% will have any kind of SCAP2, tier 2 alteration, with the commonest being B53, which doesn't have any target, followed by BI3K in almost 10%, KRAS in 7%. So we do see other like BRAF, etc., but again, the rate is very low, less than 1%. So would I actually pursue an NGS in such a patient? In my opinion, I wouldn't. And here, this is another paper showing in specific for EGFR. They looked into almost 34,000 patients. And all what they found is 27 patients with EGFR alteration. And of those alteration, which of them are being targetable is like 17 or 19. So the answer of this testing is BDL1 more than 1%, whether we really would it guide our treatment or not? HER2 was +2, FISH amplified. Folate receptor alpha was +2 and less than 75%. So what would be your treatment choice? Keynote P91 with Pembro, Bacli, Bev, Rolicurlant plus nab-paclitaxel from Rosella, TDXD from Destiny Pan tumor, or mirvetuximab from Mirasol. Can we have the voting? And I'll start, maybe there are many of these are option, but I want your preferred option. So I don't want, everyone will choose only one answer. So BDL1 positive, HER2 +2, FISH amplified. Who would vote for Keynote P96? Okay, Dr. Omaima, Dr. Hashim. One vote, huh? Yeah, only one. Right. So who will vote for Rosella? Rolicurlant? None. Yes, كلها بس أنا على histology that I have shown. TDXD. Okay. 2+ FISH amplified. And guidelines, it's there. Right. So who will vote for MERV? Okay. Right. Can we see the voting? So I see 1/3 going for Keynote P96. Another 1/3 went with Rosella. 23% went for TDXD. There is 16% who went for mirvetuximab from Mirasol. All right, so can we remove the voting? So in such a patient, you might have, and this is not an uncommon scenario. Currently, we have this challenge of having multiple options. Maybe none of them is, some of them are not available, but if you have the option, you need to have a sequence in your mind. So what would I choose? First, we have to know that these are PROC. The likelihood of going to a subsequent line is very low. So you want something very effective. You want to look to objective response rate, and you want to look to a significant, meaningful efficacy endpoint such as PFS. So if you look into Mirasol, so for the 16% who waited for Mirasol, that's a wrong answer. Simply because of it was the expression was in less than 75%. And would I actually consider it if I have HER2 positive? You need to look into objective response rate and look into what would give you a better objective response for such a patient. So Mirasol gives you like 36%. So if I have both options, even if they were candidate, I would choose HER2 for such a patient. So what do we get from TDXD in ovarian cancer +3 or +2? It's in between 50 to 60% in terms of objective response rate. Rosella gives you similar to Mirasol, around 36%, like 1/3 of patients will have a response. So how about Keynote B96? You have like 50, almost 50%, but is this really the standard? So from Aurelia study, what is our objective response rate? Because if you look into the control arm, it is more than 40%. Aurelia with chemo plus Bev alone, we know that it gives you only like 30%. So how come here we see 40%? So, but again, it gives you a reasonable objective response rate. So if I were to choose from according to response, I will choose TDXD for such a patient. So how about PFS? If it is +3, we see a PFS that exceeds 1 year. If you look into OS for TDXD, again, it exceeds like 20 months, more than 1.5 years. So how about Rosella and Keynote P96? So Rosella, the benefit is marginal by almost 1 month in terms of PFS. Overall survival, we see a trend. It did not yet reach statistical significance. B96, we have an advantage in PFS by 2 months, and overall survival from the part that was presented for CPS 1 or higher, we see a reduction in risk of death by almost 25%. So all of them are an option. If I were to choose for this patient, I would choose TDXD. My second best option would be actually Keynote P96 for such a patient. And with that, I conclude. Thank you.
Thank you so much, Dr. Mohammed. So, Professor Isabel,
Yeah, I'm there.
with us. Yes, we will open the floor for any question or discussion.
Yes,
Professor, regarding the using of pembrolizumab and platinum-resistant ovarian cancer, I saw that the design of the trial, they used a weekly paclitaxel. What about the other regimen of chemotherapy can be used here or not?
This is a good question. If you look at this positive trial, I think that the use of weekly paclitaxel plus Bev explain the positive results. However, you have to be careful. This population included in the B96 is not my own population. That means that right now all the patients in France receive Bev before, not only 40%, and very few lines of treatment, which is not the case. So the results of the B96 also are really positive. Did not report the real life we have now. And for this reason that I'm not sure that there is a lot of patients who will be candidate in the future. Then I would like to insist on something that you mentioned before about the PD-L1 expression. You're right, the press release mentioned that the trial is positive in the ITT population. However, I would like to say to you something in advance. If you look at the other ratio in the CPS1 positive, the other ratio is 0.76. If you look at the ITT other ratio is 0.82. That means that in the CPS negative population, probably the other ratio is 0.9. So I'm not sure that the pembrolizumab really reports something in the group of patients without PD-L1 expression. Also, we can discuss about this biomarker, which is not the best. And finally, if you remember the phase 2, exploring cyclophosphamide plus Bev plus pembrolizumab in the same population, we also see a difference of activity looking to the CPS positive population versus the CPS negative population. So to consider the B96, I will be in favor to consider for the PD-L1 positive expression and perhaps the PD-L1 CPS 10 more than CPS 1 could be debate. We have to look at the data and to add systematically Bev and weekly paclitaxel or cyclophosphamide, but not using only weekly paclitaxel and pembrolizumab. I'm sure that Bev play a role in this regimen.
Thank you. I have a question for Dr. Mohammed and maybe also Prof. Isabel regarding the case you presented. Suppose that patient responded to the first line maintenance. Are you going to stop at 24 months or you can go beyond that?
So if there is no evidence of disease radiologically and biochemically, I'll stop at 2 years as per the protocol. However, sometimes I actually go for 3 years, but only if there is residual.
Okay. Prof. Isabel, any comment?
It's a very complex question because right now we don't have a clear answer. At the beginning, we are quite comfortable to think that perhaps we can continue, but I don't know if you have paid attention to what we report with the PAOLA-1 data when we look at what is the activity of the platinum-based chemotherapy post PARP inhibitor. And if you look carefully, you will see that the response rate to chemo when there is no platinum is exactly the same if the patient progressed during PARP or with no PARP. However, when the patient received platinum-based chemotherapy, the response rate, if the patient did not progress during PARP, is more than 60%, quite the same for the patient from the control arm where there is no PARP. But the patient who progressed during PARP, the response rate to chemo, including platinum, is only 30%. And this is better than monotherapy, yes, but it's very low compared to the combination outside of PARP. So looking to that now, we start to be very cautious not to prolong so much the PARP inhibitor beyond 2 years to be sure that we did not impair the chance of the new line of treatment to be efficient.
Yes,
thank you for the speakers for the nice talk. Yeah, my question, because we are in the precision medicine talk about the NGS. So we need conclusion from you as expert. Do you think that it is time to do NGS testing for all the, whenever available, for all the patient, and should be using archival tissue or fresh sample? Thank you. NGS testing.
I can answer in my institution if you want, just to have an idea how we are proceeding. For the first line, we have an HRD test. We are able to also reveal several gene panel, including the mutation of P53. And you know that now we have a targeted treatment targeting the Y2020 mutation, P53 mutation. So we are using the panel, including HRD test and BRCA testing. And we have also now using some gene panel for the rare epithelial ovarian cancer, looking to the KRAS mutation, but also the PI3K. And we are thinking to also develop, depending of what's happened in the future, immunochemistry multiplex to be able to have the PD-L1 expression, the full R1 expression, and probably in the future the TROP2 and the CDH6 expression.
But would you consider comprehensive panel? These are targeted panels, am I right?
Yes, it's a targeted panel, because if we are doing everything, we will not be able to have enough material for the future.
My answer would be actually similar to you. So I would actually test whatever is targetable, and as I said, so I agree with Dr. Isabel for BDL1. If later on we witness that different expression would actually have a therapeutic role, then definitely we'll do so. We are doing similar to what Dr. Isabel is saying, BRCA, HRD, KRAS, P53, all of these things can be done in a targeted panel. But from the evidence that I showed, there are many alterations. However, they are all SCAT tier 2. And if you are able to use off-label medications in a molecular tumor board, then it is going to be useful. If you don't have the luxury of using these medications, then you will be doing it with no good reason.
Just one more question. I have one patient who progressed at the end of olaparib maintenance with olaparib Avastin. And she had almost grade 3 to 4 peripheral neuropathy. So just I want to hear from you, what could be your preferred combination for this patient?
So there is actually a phase 3 trial that looked into this, assessing the use of Calyx versus GEM. And Calyx was better. You are trying to avoid peripheral neuropathy, so paclitaxel is out of the picture. So if I were to choose a platinum doublet, I'm going to choose it with liposomal doxorubicin. And here I would continue bevacizumab based on the evidence I presented earlier. How about you, Prof. Isabel?
You see, you Bev after Bev, is that your question?
No, what doublet, and would you give Bev after Bev or not?
We are using BEV after BEV now because the BEV is very cheap and we have the Mito-16 as you mentioned before. And the question is about the patient who did not receive PARP before. In the first line, all the HRD positive population receive PARP. So that means that there is only the HRP. And in this group of patients, few are really responding so much to chemotherapy alone to consider not to use BEV but to use PARP. The question about Paola 2 regimen could be interesting to explore, but we don't have data right now.
I think by this, for the sake of the time, we will conclude this session. Thank you so much, Prof. Isabel. Thank you, Dr. Mohammed, for this excellent presentations and discussion. And we will move to the satellite symposium.
Thank you so much. Bye-bye.
Move the slide from here. Move the slide from here. Enter. Assalamu alaikum. Now I'll present the satellite symposium for the ABRI. My talk will be about addressing the unmet need in platinum-resistant ovarian cancer. Here's my disclosure and disclaimer. So as we know from the previous talk, that Jason, you do this. Is this my first slide? Not. So as we all know from the previous talk, that is now ovarian cancer is still a major medical issue, and it's account about the second most common gynecological malignancy with significant increase in incidence as well as in the mortality. And we know that is the rate of new cases is increasing. Typically, it's disease of the patient above age of 50 years. The major issue with ovarian cancer is the late presentation, because majority of those patients, they do present in advanced stage disease, which is significantly affecting their outcome and even the option of treatment. So ovarian cancer has remained an unmet need in medical treatment. If we look globally, it's account about the 8th most common diagnosed cancer in women worldwide. The incidence worldwide is exceeded 300,000 per year. And we can see that is the mortality per year is exceeding 2,000 patients per year in terms of mortality. So if we talk the estimated incidence over all the years, we can see the incidence is increasing, the mortality increasing, and the outcome of ovarian cancer is also getting worse and worse with multiple line of treatment, because we know those patients, once they have, majority of them, they will have relapse. And once when they have the relapse, we're talking about more of palliative treatment rather than curative intensive treatment. So, go back. So ovarian cancer epidemiology, as we said, we talk about the incidence, 70% they will have relapse, and the 5-year survival is 30 to 50%. When we talk about the Middle East, Africa, and Russia incidence and the mortality, we can see worldwide the significant increase in the incidence and mortality. And our reported different country, we have different number of the incidence. We talk about Saudi Arabia, it's almost about 400 cases per year. Other countries like Egypt, they have more than 1,000 cases per year. And we're almost having the same mortality rate between 3 to 4%. In Saudi Arabia, we have our incidence reported about 400 cases per year, and our mortality is 2 to 3% overall. We are not different than other parts of the world. We have our patients, most of them, 2/3, they are presenting in stage 3 and 4 of disease. So how does this affecting the patient's survival outcome? Because those they presented in later stage disease, majority of those patients, they will relapse and eventually they will die from the disease. Why ovarian cancer presenting in later stage? Because we know there is no specific symptoms for ovarian cancer. When those patients really present with the significant symptoms, it's basically reflecting the metastatic disease and separate in the peritoneal cavity and ascites. And today we have no any tool or method for early detection of ovarian cancer. And as we hear from the previous talk, we don't have any screening tool for the ovarian cancer for the general population. Here is the landmark for drugs that approved in ovarian cancer therapy. We can see for the last decade, we have significant improvement and changes in the modality, the way we treat ovarian cancer. Maybe 20, 30 years ago, there was no other option other than surgery or chemotherapy. For the last 10 or 15 years, we're talking now about maintenance therapy, which make big difference in the patient outcome, and other target therapy. We have bevacizumab, maintenance therapy, different type of PARP inhibitor, and nowadays they have different target therapy. We heard from the previous talk about the target therapy and next gene sequencing and different modality of targeting those cancer patients. If we can we see this curve here? The patient usually they have the best response and the best duration of response after the first-line treatment. After surgery and chemotherapy, they may gain 1 or 2 years disease control or remission. But once they recur, which is actually 70% of them, they will recur. They usually have a multiple line of treatment. We can see in this curve, the maintenance therapy has big difference in the recurrence rate or at the time of the recurrence, because we are gaining more time with adding the maintenance and upfront line. The patient, they do have longer progression-free survival and better overall survival. And as we all know, the maintenance therapy is manageable, and now it's a standard of care in the first-line treatment of ovarian cancer. So how this maintenance therapy affects the treatment of ovarian cancer? If we can see the incidence, there is almost the same, but if we can see, we have the significant increase of prevalence of ovarian cancer. Why is that? Because patient now is living longer and longer with ovarian cancer, though they still have disease, but we're still getting some more time and they are living long with the treatment. And this was reflected also in the rate of mortality. Here is the cycle of a treatment of the patient. As we can see here, the first cycle of treatment, usually the patient, they may gain, the good patient, they will live 1 or 2 years in remission. But once they recur, the time of remission getting less and less. So from 1 or 2 years, we're coming to 6 months, 2 months, 3 months. Eventually, all of these patients, they will consume different line of chemotherapy. And unfortunately, all of them, end of the road, they will become platinum resistant and they will die from the disease. Here we can see, once they have a recurrence, you can see the curves, the duration between each line and the other line is getting shorter and shorter. And by end, they will have the complication of disease and die from it. And this is the era where now it's need really significant improvement or changing the way we are treating them, because we are doing great in the frontline treatment. We are really getting good benefit for the patient. But once there is a recurrence, there is still unmet need that we need to do something more in order to improve this outcome for those patients. Here is the definition of platinum resistance and platinum sensitive disease. I think this was well covered in the previous talk. We know the platinum sensitive disease is those the type of patient who's usually they respond very well to the subsequent line of platinum treatment with good response. However, for those who have platinum resistant, the response to platinum baseline treatment usually is poor. And this is reflected to the median progression-free survival and overall survival of those patients. And as I said before, a majority of those patients, by end of the multiple line treatment, they will become platinum resistant. So how we diagnose platinum-resistant disease? Yes, it is about the duration of the recurrence of disease, but how we detect when they have the progression of disease? Basically, there is no standard that how we detect or identify platinum-resistant disease or recurrence, because this is based on the clinical assessment and the biomarker and radiological assessment. So we cannot guarantee that this image was done exactly on the time of the disease progression. Sometimes we are just finding the finding that may be there for maybe 2 or 3 months before. So it's not an accurate measure, but this is what we have. So it's not really standard method to identify platinum resistant, but we should be always thinking about the proper assessment of the patient, because the key here is to identify the recurrence as early as possible, and because this will affect the decision to decide whether they are platinum sensitive or resistant, and subsequently will affect the decision of subsequent treatment. And keep in mind, most patients with platinum resistant, they don't usually respond very well to chemotherapy. And for those of first line or early line treatment, they have a good performance. They can tolerate more line of treatment with a good quality of life. But with multiple line of treatment, those patients usually is exhausted from chemotherapy, and the benefit of the chemotherapy is very limited. So we have to weigh the risk and balance with the benefit versus their quality of life. Because the benefit of them after multiple line of chemotherapy is very diminished, it's very little. So always it's not wrong to decide that we should stop treatment for those patients in order to give them a good quality of life or end of life of care. Here again about platinum-resistant disease represents still unmet need. As we said, majority of the patients, they have platinum-resistant disease. Still, they don't respond very well to chemotherapy. As mentioned in the previous talk, the response usually is about 10%, and there is no overall survival benefit from the further chemo treatment for those patients. However, now as we heard from the precision medicine or precision talk, that is now the targeted therapy can make difference for those patients and may affect their term of objective response and overall survival benefits. Here is the NCCN guideline. As we see, we have a long list of different options that can be used in the platinum-resistant disease. We can't say that one is superior to other. I think the decision is based on what have been used before, how is the patient performance, and the toxicity profile, and decide according to the patient scenario. What about bevacizumab? I think we have a good talk about bevacizumab today. Bevacizumab is a very good drug used in ovarian cancer, whether in frontline or recurrent setting, showing a good benefit in terms of disease control, progression-free survival, and overall survival. And this is also has been proven to be effective in the patient with platinum-resistant disease, as we see that as the objective response with addition of bevacizumab chemotherapy platinum-resistant disease is better than chemotherapy alone. So there is the modern approach in treatment in the era of ADCs. As we know, this is now the standard treatment. Chemotherapy, maintenance therapy. Then when we come to the recurrence after multiple line of treatment, now we have the era of ADCs that we need to test those patients for a specific target and consider who's the patient is candidate to use those medication after they failure multiple line of chemotherapy. Just briefly here about the several ADCs now in the latest stage development for the treatment of platinum-resistant ovarian cancer. This has expanded the therapeutic option, as mentioned before with the talk of Dr. Mohsen, that we have the folate receptors, HER2 and CDX, those all the target therapy that addressing the use of ADCs in ovarian cancer. What's biomarker or predictive? We have excellent discussion now before in the previous talk whether we should test or whether we should pull panel or no. As we see, we have a list of different tests that can be used. Maybe the most common one we are using is the BRCA and HRD MMR status, but other I think different from patient to decide to use or not. And the key of using this test is to offer the patient extra treatment. There is no point to do the test if there is no drug approved for this specific testing. So we have to put it all together. What is the target and what is the effective drug that can be targeted specifically this biomarker? And this is very important when we talk about the platinum resistant, because with platinum sensitive, we know they will do well with the platinum, but with platinum resistant disease, I think this is the group of population that we really need to focus on looking for a target therapy and to improve their outcome. The question still need to be addressed is what is the best drug to be used and what is the test what we need to do and when should we do the test? Should we do the whole test for all biomarker or should be selected based on the patient presentation? This is still need to be addressed. The emerging classes of cell surface receptor providing an opportunity development of targeted ACC therapy and novel biomarker, and keep in mind the ideal target that we look for is the target with high expression in the tumor cell compared with a normal cell. The same here, just showing the several other therapies that is used in platinum-resistant disease. Now it's very promising. Now we have folate receptors, HER2, usually now used in the recurrent disease to look for the patient with a high expression to decide about use of ADCs, and other also targeted therapy in the pipeline of treatment of ovarian cancer. So the take-home message from this presentation that is ovarian cancer is still a major burden disease that we need to do more to improve our patient outcome. The patient with ovarian cancer, they usually present with advanced disease, and most of them, they will have recurrence despite the good frontline treatment. Once the patient, they have recurrence, subsequently, they will have multiple line of treatment, and eventually they will become platinum resistant. Nowadays, emerging ADCs and target therapy is the hope and to improve those patient outcome. By this, I'll end the presentation. If you have any question. Any question?
Thank you so much, Dr. Nashmiya. My question about the folate receptor alpha. Are you doing it in the original pathology or in the recurrence? Which is better to do it? Or there is no difference?
No, about this, it's not yet available, but when we do it, I think as of now, we do it in the county test. Personally, I believe we should know it from the beginning.
From the beginning.
From the beginning, but I'm not aware that there is an guideline that we decide that we should do it. But because we know this is the patient, when they repair, you need to have some disease demographic or data that will help you in the future what is in the next system. But this is one of the questions that we, it's not only political support, even in others. Because HRD, we don't get it at the time of diagnosis. Folate receptor now is recruited at the time of the recurrence to check for it, but maybe in the future, we have to test everyone from the beginning.
And it is only tissue. There is no blood test. I know. Only tissue. Okay. Okay. Thank you.
The idea is to look at expression of the folate receptor in the tumor cell. Usually they have high expression compared to the normal cell. We also have high expression.
Thank you.
Dr. Nashmiya, if the patient is candidate for both trastuzumab deruxtecan, she is here to the 3+, and at the same time she has high expression of folate receptor. What will be your choice?
Which one I would choose first? I think it depends on what you have available. Whether you have the test, if you have the test, if you have the drug available. But there's no arm-to-arm comparison. Most of those people, the same thing when we say the patient is the computer or the other markers, when you start a medical. So I think yes, we can know exactly the ideal algorithm that we should follow and doing the test as well as in other investigations. But the future is promising. This is ongoing the trial now. We have to work understanding the target therapy, the food testing, when we should be doing the testing, and then we have to pick the priority which drug should be used as a first line, second line, third. But as of now, all of these don't do the test.
Assalamu alaikum wa rahmatullahi wa barakatuh. We would like to thank you for attending this first day of our event, Masterclass of Gynecological Malignancies. And we would like to remind you that tomorrow we will be starting at 9 a.m. Thank you for joining today, and we wish to see you tomorrow. Let me clarify one thing that regarding your CMEs, all the information regarding the CME and the targeted audience are available on the link, which I'll be sharing in the chat right now. In order to get your CME, you need to be of the target audience. You need also to attend the full 2 days and to make sure that you are filling the attendance link at least 2 times per day. After that, you will be receiving an email to evaluate the event. Based on that, you will get your CME and certificates. For those who are attending from outside KSA, unfortunately, we cannot send CMEs globally, but we can send you your certificate of attendance, and we wish to see you tomorrow as well. So please make your calendars to join tomorrow 9 a.m. شكرا لانضمامكم في اليوم الأول من مؤتمر الأورام الخاصة بالأمراض النسائية، ونأمل أن نراكم غدا صباحا الساعة 9. بالنسبة للاستفسارات الخاصة بساعات التعليم الطبي المستمر، سنضع الآن لينك في الشات بوكس في صندوق المحادثة. في هذا الشات بوكس، في هذا اللينك تستطيع الوصول إلى جميع المعلومات المتعلقة بهذا الإيفنت، ومنهم الفئة المستهدفة والساعات والأجندة وكيفية الحصول على ساعات التعليم الطبي المستمر. نتمنى لكم جمعة مباركة وهاف نايس ويكند ونتمنى رؤيتكم غدا صباحا إن شاء الله على نفس اللينك الساعة 9 صباحا. وشكرا جزيلا لكم. بارك الله فيكم والسلام عليكم ورحمة الله وبركاته.